Bismillahirrahmanirrahim. Qul huwallahu ahad, Allahu samad, lam yalid wa lam yulad wa lam yakul lahu kufuwan ahad. Sadaqallahu al-azim. I am Dr. Saira Hafiz Kamran, Assistant Professor at Institute of Pharmacy, Lahore College for Women University. And I welcome you all to this webinar. I now invite Professor Dr. Humaira Majid Khan to say the welcome note to all the renowned speakers.
First of all the dear speakers and participants and my dear students, Assalamu alaikum. It's a matter of great pleasure that this is the second webinar that Institute of Pharmacy is organizing with the faculty members Dr. Saira, Ms. Baska, and Ms. Nabila. The title of the webinar is very interesting. It's the clinical management of the patients suffering with COVID-19 and the measures and challenges. I'm here very grateful to my international speakers, Nadia Bukhari, Mehnaz Khan, and the national speakers, Dr. Muhammad Asim Rana, Dr. Kamal Rahman, for giving their precious time for this webinar. I would glad to thankful to my Vice Chancellor, Professor Dr. Bushra Mirza, who always welcomed us at the nick of the time for their valuable suggestions, advices, and speech. I'm thankful to my faculty to withstand in these circumstances and to organize such beautiful webinars for the students of pharmacy. Here I would like to introduce my institute in a few lines, that we are not the best, but we are different. Our students, we have passed the 13 batches of PharmD, and it's a great pleasure for me to announce that our students are playing immense role in the profession of pharmacy throughout the country. Why I'm saying throughout the country? Because we welcome all the girls from throughout the country to be the part of the Institute of the Pharmacy. Our students are in industry, in community pharmacies, in hospitals, in drug regulatory authorities performing very well. I also like to tell you that we have a number of PhDs now, and our newcomers, faculty members are doing the PhD, and their PhDs will be completed soon. So we will have a great number of PhDs in Institute of Pharmacy. Again, I would appreciate the efforts of the Vice Chancellor, who gave us the status of Faculty of Pharmaceutical and Allied Health Sciences. And lastly, but not least, I'm very much thankful to all of you, and I wish you good luck to all my students, to all my faculty members for their future. Be safe, be protected. Allah is with you. Thank you very much.
It gives me immense pleasure to welcome you all to today's webinar entitled Clinical Management of COVID-19 Patients, Measures and Challenges. Clinical pharmacists are a very important integral part of our healthcare system. In COVID-19, we saw them working side by side with doctors and nurses to perform their role in managing COVID-19 and helping the patients. In LCWU also, we saw our pharmacists playing a very vital role in developing SOPs and policy for COVID-19 and its implementation as well, so to make safe everybody's life at campus. I congratulate our Director of Institute of Pharmacy, Dr. Humaira Khan, for organizing this seminar, and I congratulate her team also for managing this seminar, and I am especially thankful to our resource person, Ms. Nadia Bukhari, Ms. Mehnaz Khan, Dr. Muhammad Asim Rana, and Dr. Kamal Rahman. I'm sure their experience, which they will share with our students, will be very helpful for our students and general faculty members. I wish you all the best. Thank you. It gives me immense pleasure to welcome.
Dr. Saira? Dr. Saira, please introduce your first international speaker so that we can know about
sure.
ideas.
Yeah. Our first speaker is Nadia Bukhari. She is academic pharmacist and global pharmacy ambassador at University College London. She is the youngest female fellow of the Royal Pharmaceutical Society, making her the first British female Muslim and first female of Pakistani origin to be a board member. She has a global reputation in countries such as Pakistan, UAE, Oman, Poland, Greece, Brazil, Portugal, Italy, and Belgium, where she has advocated the role of the pharmacist in United Kingdom. Via her role as an educator for pharmacy undergraduates to her position as chair for the Royal Pharmaceutical Society National Conferences, she directly interacts with almost every trainee pharmacist in England. She has also been appointed as the global lead for gender equity at the Workforce Development Hub for the International Pharmaceutical Federation. Nadia is also an ambassador and on the board of trustees for Pakistan Alliance for Girls Education. It is a strategic organization which is supported by the government of Pakistan, which promotes gender equality in education. And this has made many more girls to go to school in Pakistan. She has also launched the National Alliance for Women in Pharmacy in Pakistan to promote gender equity nationally for female pharmacists. She has been playing a major role as the chief pharmacist at Doctors, which is a telemedicine platform providing telemedicine services extended to Punjab-wide in response to COVID-19 pandemic. Doctors is working in collaboration with the government organization, Punjab Population Innovation Fund, and University of Health Sciences. It's a pleasure to have you, Nadia, with us today, and over to you. Yes. Nadia, it's mute.
Oh, can you hear me now?
Yeah.
I'll start again. Assalamu alaikum and Bismillah ar-Rahman ar-Rahim. Thank you very much for that humbling introduction, Dr. Saira. It's an absolute pleasure and an honor to be invited as a speaker for your conference today. And I'm very excited to be addressing your students. So a very warm welcome to all faculty members who are on this conference webinar, as well as all our amazing pharmacy students. So, Dr. Saira, you've asked me to speak with regards to the COVID response that pharmacists have made, especially in the UK, but I'm also going to touch on some of the work that I've done with regards to the pharmacy profession in Pakistan during the whole pandemic, if that's okay. So, as we can see, the pharmacy leadership response has been clearly evident during the pandemic, and we have been right at the forefront. Pharmacists have continuously been at the front line, open access healthcare profession. We've always have been. We've been the experts in medicines, and that's what makes us unique from other healthcare professionals as well. You don't need an appointment to see a pharmacist, and we really pride on that as well, for being open access and available all the time for our patients. Not only supplying medicines and managing patients' medication therapies, but we're also providing essential services such as diagnosing and treating minor ailments, chronic disease prevention, and monitoring chronic conditions. Pharmacists and their teams are making an incredible contribution to healthcare provision during the pandemic, and we have stood as leaders in the delivery of healthcare in the time of crisis. And this is something that we really should be proud of. We really should be proud of our profession, and we should be proud of being a pharmacist. And for our students who are studying at the moment, we should be proud that you are studying such a vocation and a professional course. So at the start of the pandemic, when the world was near enough total lockdown, there was an even greater dependence on pharmacists as the first point of contact to fulfill the public's healthcare needs. As you know, many doctors' surgeries had closed and moved onto phone appointments, and we had the same here in the UK as well. And pharmacies were one of the few places that were kept open for the public, making pharmacists and their teams a fundamental healthcare provider during the outbreak. The public turned to the pharmacist who led the provision of support and advice during this time. And we also remained on the forefront of public health by serving as direct points of access for our patients. We had to disseminate accurate and current evidence-based information regarding COVID-19 to the public. This was a key focus for us as public and patients didn't know where to go, who to call, who to access. And with pharmacists being one of the most trusted professions worldwide, people were turning to us for support and advice during the pandemic. And we had a role there to calm people down and to manage anxiety levels. All of these additional responsibilities were rapidly taken on by the pharmacist and their teams, as well as continuing with normal service provision of medication supply and management and usual essential services that we do as pharmacists. It's been a very busy time for the profession, and I'm sure if you speak to any pharmacist who's been working during the pandemic, they will tell you the same. It doesn't matter where in the world, be it UK, Pakistan, UAE, wherever. It's been a very busy time for pharmacists. We've shown great leadership traits of perseverance and diligence during this time. And we have risen to the challenges that COVID has thrown our way. And we've come through, alhamdulillah, shining brighter than ever. During the pandemic, pharmacy teams have been swamped with dealing with medication shortages and procurement issues, and more importantly, meeting the needs of every patient who visits the pharmacy requiring support and advice. In the first few weeks of the pandemic, the workload had almost tripled in some areas within the UK, adding to increased pressure and burden to the pharmacy teams. Now, through solid teamwork and working above contracted hours, we were able to manage patients' needs above and beyond expectations. Here in the UK, we've had cases they've worked around the clock during the pandemic. We've had pharmacists themselves delivering medicines to patients, as well as managing patients' fears and concerns regarding the coronavirus, which has contributed to mental health issues in some patients. We're also seeing, unfortunately, a significant increase of domestic violence cases, which is a grave concern during the pandemic. And again, to deal with this demand, victims are being directed to their pharmacies as safe zones and are able to speak to their pharmacist in confidence, who are then able to signpost them for appropriate support. And in countries like France, there's actually a code word, a keyword, which women or any victims of domestic violence can actually use when they come into the pharmacy and use that code word. So then the pharmacist will know that this person needs support. So, pharmacists have really gone above and beyond during this pandemic. In hospitals here, hospital pharmacists, they've not only been supporting the clinical care of existing patients, but also the critical care of COVID positive patients. And one example of how they've been doing that here in the UK is by having ready to use critical care drugs for use by nursing and medical teams. The global desperation of finding treatment for the coronavirus is increasing. Pharmacists, as I've said before, we are the experts in medicines. We are essential in facilitating investigational evidence-based medicational studies, but also central to the procurement of such treatments. As we know, there's a lot of fake news circulating regarding breakthrough treatments that can save lives. Pharmacists are the best placed and have been offering the correct advice and support around medication use and risk to the public, as well as members of the healthcare teams and policymakers. The profession here in the UK gained a long-awaited recognition from the government during the pandemic as a reliable, informed, and credible resource and an integral part of the National Health Service family. And this acknowledgement further boosted the morale of the profession. And I also know that the same happened in Pakistan when our former health minister, Dr. Zafar Mirza, had also done the same via a tweet, and he gave recognition to the whole pharmacy profession on their outstanding work during the pandemic. And this is something that we've really got to hold on to, and this has given us not only morale, but has made us feel valued, not only in the eyes of patients and the public, but amongst other healthcare professionals, which is so important. So as Dr. Saira mentioned as well, I'm Chief Pharmacist for Doctors, which is a leading telehealth provider in Pakistan. And telemedicine has highlighted the importance of telehealth as a sustainable solution for healthcare provision, especially during the pandemic, and one where we must also incorporate the pharmacist. Now, if we actually look at telehealth, it's helped expand access to care at a time when the pandemic has severely restricted patients' ability to see their doctors. With the closure of OPDs in the private and public hospitals, there's been a great unrest amongst patients with other diseases, because right now our entire focus has been COVID, and we forget that we have patients suffering with diabetes, heart conditions, cancers, etc., and they have also needed support during the pandemic, which has really increased the workload of all healthcare professionals. COVID-19 has caused a massive acceleration in the use of telehealth, and we're seeing providers rapidly scaling offerings and are seeing at least 50 times the number of patients via telehealth than they did before. The potential impact is improved convenience and access to care. We're having better patient outcomes via telehealth, and obviously it's a more efficient healthcare system. Now, many of these dynamics are likely to be in place for at least the next 12 to 18 months, as concerns about COVID-19 remain until we have a vaccine widely available. And we're all very strongly and relentlessly praying that this happens sooner rather than later. So there is, a thought that this could be telehealth and telemedicine could be then a more sustainable way forward when it comes to the sustainability of healthcare provision, especially in Pakistan. With the doctors, nurses, and paramedics physically present in the emergency, isolation wards and quarantine centers, pharmacists can hold on to this end and can ease patient distress by providing triaging and basic consultations via telemedicine, taking the burden off doctors and the health system. Giving advice on minor ailments, as I've said before, we do that anyway over the counter, and dealing with minor conditions, like cough, colds, flus, diarrhea, nausea, etc. There's a great deal of opportunity to actually incorporate the pharmacist into telemedicine teams, and something which we have actually started to do at Doctors, and we are very proud of incorporating pharmacists into the team. So telepharmacies can be implemented in retail, outpatient, mobile, or hospital settings. And a typical telepharmacy involves a fully licensed pharmacist at a remote site who provides consultations and supervisions to a community healthcare worker at a rural site. And this is something that we are already working on at Doctors, working with the rural community and providing healthcare provision, but also access to pharmaceutical care in the rural areas. The pharmacist can verify prescriptions, assess the appropriateness of the dose, and ask for clarifications before approving the order. The community healthcare worker and the pharmacist communicate through telephone or video conference, and maybe even electronic healthcare records in the future, or another form of secured electronic connection. Around the world, there are many programs that also use telehealth to record images of the prescription, medication, label, or prepared bottle for additional review by the pharmacist. Another key component of telepharmacy is patient counseling and education. And many telepharmacy programs require pharmacists to conduct a live video consultation with the patient prior to releasing a prescription. In some telepharmacy models, we've seen that, especially those located in hospitals, the rural site is equipped with an automatic dispensing unit that contains pre-packaged doses of medication. And like I've said before, our focus really is on the rural communities, and we're using this to increase access to pharmacy services. And of course, there are many challenges when you're working in the rural areas, and it's important then to have access to a Wi-Fi connection, to a tablet, which we actually give our community healthcare workers access to. And I'm very excited at Doctors to actually be leading on this, and we will be growing our pharmacy team as well, inshallah. Now, COVID-19 has also presented a unique opportunity to address gender-related disparities within the pharmaceutical workforce. And pharmacists are combating COVID-19 within their communities as frontline responders, as I've already mentioned. With the shortage of global health workforce in combating the outbreak, pharmacists provide a valuable resource that can be effectively utilized to provide critical medicines, medical supplies, as well as serve essential healthcare needs of communities. So therefore, including female pharmacists in key decision-making, policy and pharmaceutical workforce is only a natural fit in global efforts to combat COVID-19. As Dr. Saira also mentioned, I'm also the founder and patron-in-chief for the National Alliance for Women in Pharmacy in Pakistan. And we've been looking at COVID-19 through a gender lens as an organization. And we know that over 70% of the global health workforce are women. And by 2030, over 72% of the global pharmacy workforce will be women. So pharmacy really is a female-heavy workforce, and we've got to start thinking about how to make pharmacy more accessible for women, but also once they are in the profession, how we can actually grow them, mentor them to become leaders of tomorrow. So the COVID-19 pandemic appears to affect men and women in fundamentally different ways. And with the exacerbated gender inequalities in its aftermath, it's highlighted the need for women's leadership in the COVID-19 response. Men have seemed to have higher fatality rates amongst all age groups, while we've seen that women seem to be widely impacted socially and economically due to their increased burden of housework, childcare, and informal care within families as mandatory lockdowns and stay-at-home orders have been put in place to slow down the virus. However, the global response to the pandemic appears to be a gender-neutral with underrepresentation of women in decision-making bodies, and only a limited number of countries collecting sex-disaggregated data on COVID-19. The perception that women are not relevant to the COVID-19 related policymaking is a myopic and short-sighted approach, as it assumes that women need to be disempowered to play a key role in addressing it, when the prime victims of this pandemic are disproportionately women. The lack of gender lens in the COVID-19 response is only a reflection of the lack of gender parity within the global health force. Now, the World Health Organization, they have published a report called Delivered by Women and Led by Men. And this, as I've said before, highlights that while 70% of the global health workforce are comprised of women, only a limited number of women are in leadership positions. And we're seeing similar trends in the pharmacy global profession as well. Women continue to be underrepresented in senior and leadership positions within pharmacy, despite outnumbering the men in global pharmacy workforce. And the International Pharmaceutical Federation, as I've said, has predicted that more than 70% of the global pharmacy workforce will be women by 2030. So despite lockdowns and stay-at-home orders, most pharmacies around the world, as I've mentioned before, they've stayed open to provide critical healthcare services and supplies, and the women have been at the forefront. Pharmacists are the first point of contact between individuals and healthcare systems, providing a crucial information to individuals regarding hygiene, countering myths and misinformation regarding to COVID, but also providing emotional support during this time. Pharmacists are also playing a very critical role in addressing domestic violence issues, as I've mentioned before. And as women make the majority of the pharmacy workforce, female pharmacists are vital in tackling the coronavirus crisis and in addressing hurdles females are facing. Therefore, COVID-19 presents an ideal opportunity to not only address the gender-related disparities within pharmacy, but also to promote females' leadership within pharmacy. And there's so much evidence available suggesting that investing in a female health workforce saves lives. So it not only strengthens health systems, but it is also an essential step towards achievement of a universal health coverage and sustainable development of the goals. So we know in Pakistan that the pharmacist ratio to patient is only 0.9 pharmacists per 100,000 population, of which 70% are engaged in industry and a very small core serving in the health service delivery. So while organizations, authorities, and hospitals were arranging personal protection equipment, PPEs, for doctors, nurses, and paramedics, there was no attention being paid towards the protection of pharmacy teams. Even though pharmacists are at the front lines, we are the first line of contact for the public in normal situations, but even more so in the COVID-19 pandemic. And as said before, because there was no access to any other healthcare professional. So pharmacists really needed some kind of guidance and guidelines to stay safe so they can continue to serve the public and their patients. So assessing this scenario, pharmacists in the UK and Pakistan, we teamed up together to compile a 10-step protection guideline for pharmacy teams in Pakistan, both in English and in Urdu. And this was endorsed by the Ministry of Health, it was endorsed by DRAP, as well as the PPA, National Alliance for Women in Pharmacy, FIP, and doctors. And these guidelines can be adopted and adapted by any country, keeping in view their own laws and regulations. And you can find these guidelines available on the DRAP website. And we're very grateful to DRAP, who actually have been very, very supportive in the writing of these guidelines. So being on the front lines during this time, it's meant that pharmacists and their teams have had to adopt precautionary measures, not only to safeguard the public, but themselves too. We have had a number of very unfortunate COVID-related deaths within the pharmacy community. Pharmacists have placed great emphasis on the health and safety of their teams and the public. Many pharmacies have had added perspex barriers at the counters and have incorporated social distancing protocols, limiting the number of people that enter the pharmacy, as well as hand sanitizing areas and the wearing of masks. What's working within COVID-19 hotspot communities and hospitals, pharmacists have shown that as leaders in healthcare, they are knowledgeable, relentless, resilient, and courageous. COVID-19 has highlighted the importance of pharmacists and their teams with regards to their role and the support that they offer the community. As we move out of the acute phases of the pandemic, we need to cement the recognition received during this time, that we are an integral part of the healthcare team, and as leaders within our own right, we must ensure that wherever there are any matters related with medicines and its management, there must always be a pharmacist present. Thank you very much. Thank you, Dr. Saira.
Yeah, thank you, Nadia, for your such informative and majorly, I would say, female related talk and importance of the female pharmacist during the COVID-19. There's a question from the audience that as far as doctors is concerned, is it providing any role to the graduated pharmacists, the ones who have already graduated, and are they able to provide any role in doctors?
Yes. Absolutely. So this is something that I'm working on, and that's why I've been taken on board with doctors to actually start developing the pharmacy side of telemedicine. So my advice would be watch this space. There will be recruitment calls with regards to having a pool of pharmacists that can offer remote telemedicine telepharmacy services like counseling patients on over-the-counter remedies. and counseling and what have you. So do watch this space, and this is something I am working on and very excited about, because I don't think there's any other telemedicine company in Pakistan that is actively recruiting pharmacists to work alongside the doctors. So this would be like an integrated approach, not just telepharmacy. It will be working with the doctors who will be doing the diagnosing. They will then refer them to the pharmacist, who will then provide counseling and minor ailment strategies to patients.
Have you been getting, calls from the Punjab across on doctors?
Yeah. So
how actively?
So we have partnered with PPIF, as you said, with the Punjab Population and Innovation Fund, specifically on maternal, neonatal, and child health. So it's an MNCH helpline. And during the pandemic, we've had a lot of women calling us who've been very concerned about their reproductive health. But funnily enough, we've had men also calling as well with regards to the kind of contraception they should have. So newly married couples, we've been having men phoning us as well. So yeah, it's quite refreshing to see that people are now adopting this new way of accessing healthcare.
Thank you very much, Nadia, for being with us. It was a pleasure having you and also sharing such information with our students and our audience. Thank you.
Thank you.
Thank you. Thank you very much. Our next speaker of today's webinar is Mehnaz Khan, who is a senior clinical pharmacist at Chesterfield Hospital NHS Foundation Trust. Her major role is to provide clinical support through medicine information. She maintains and updates clinical guidelines and local formulary, facilitating education and training in medicine information. She also assesses and evaluates new drug requests, participating in medication safety and drug therapeutic agenda. She also helps in providing information and support to patient helpline. She also maintains information resources, actioning drug and safety alerts. In addition, her role is in medicine optimization with emphasis on de-prescribing in the elderly, providing prescribing support to clinicians, regular medication reviews, facilitating safe and effective discharges, participating in multidisciplinary decisions making and consultant-led ward rounds. Mehnaz has more than 10 years experience at various hospitals as a clinical pharmacist in UK. It's a pleasure to have you, Mehnaz, with us and to share your experience. You have to unmute.
Assalamu alaikum, everyone. Thank you very much for having me. Saira didn't mention that I'm an ex-PU graduate as well. So I did my BPharm from the University of Punjab, and this was in 2003. So it's been a long journey. And it's really nice to connect with all of you and share my experience as a pharmacist so far. I hope you can hear me because I have a few IT issues with my iPad and I'm on my phone as well.
Yeah, no problem. Mehnaz, we can hear you.
So I think for me, I just want to share the experience and the challenges we've had in an NHS hospital in the UK. Obviously, it's been a learning curve for everyone, you know, even in the developed countries, it's had its, you know, challenges, and we've learned along the way. It's not like we knew everything from the word go. We had some time to prepare, which was useful because we put some measures in place, and we found ourselves in a much better place than had we not had the time, because I think some countries had to just deal with it in the Europe, like Italy, but luckily with us, we learned from what they were doing, and we kind of then put our own systems in place to make sure that we were a better well prepared. But with COVID, as you all know, any preparation sometimes is no preparation because it's such a new virus and we're still learning about it. And we've had to change our ways of working, like Nadia said. I mean, community pharmacy was really instrumental in England because a lot of GPs weren't working from normal GP surgeries. The hospitals were literally shutting down because we couldn't afford to get patients in, and we really had to risk assess patients and see which ones were more eligible for urgent or immediate treatments, you know. So outpatient departments were really affected. And as pharmacists, obviously, we had our own challenges, but luckily we had we could provide a lot more support to our colleagues, and we went into virtual mode, and we did a lot of working from home as well to kind of keep up with the pace. So I'll just share that experience of mine. I am obviously, I was involved more with the clinical trials and obviously the medicines information side of things, because we had to provide support to high dependency units, IT units, in terms of making drugs, stability information. So I did a lot of research around that, but I can also share some experience based on what my colleagues had to go through. So I think the main areas that we struggled with in the NHS hospitals was one, resources. So there was human resource crisis, equipment, medication shortages. For resources, for example, we had strict quarantine rules in place in the hospital. So early days, because we didn't have any antigen testing, it was quite a new time for us. Anybody who had a cough, literally, and a bit of fever, they had to quarantine at home. And that affected us on the ground because clinical pharmacy in England is a big thing in the hospitals. Pharmacists are instrumental. We are on every ward providing essential services. And with the workforce being affected, it wasn't going to be feasible to be able to support our staff. And also we had to double up, on a lot of resources. For example, we have 2 HDUs, we have 2 ITUs, we had to have 2 admission units, just because we were trying to separate the potential COVID and non-COVID patients, and that took a toll on staffing. So a lot of my colleagues had to skill up very quickly in ITU skills, HDU skills. We had to find new ways of working. So luckily we had electronic prescribing. So we did not have to be by the patient's bedside all the time. And we could access medication histories, clinical, labs, and vital statistics on the touch of a button, which I think is the way forward for a lot of hospitals now. So there is a drive to kind of electronically, have a lot of virtual or electronic platforms to be able to do that. And we really, as pharmacists, were in an excellent position to do that, because our prescribing was all virtual. We could be sitting away in our homes and screen patients, for clinical errors or validate their medication. And we had buddied up with colleagues who were on the ground to be able to help us with any clinical input if we needed. So, for example, we had colleagues who couldn't be at the hospital because they were ever pregnant, especially if you're ladies, or if you are in a high-risk category. So, for example, if you've got any autoimmune conditions, or if you're on autoimmune diseases, the NHS obviously had to risk assess their staff. And if you are in that category, you could physically not be on a ward. But we were using electronic prescribing to be able to buddy up with people who are able guidelines to reflect that. We had to use gravity infusions rather than infusion pumps to be able to do that. And we had to look into research again and find then safely administer medication quickly, and also use the resources that we had. Then also in terms of the nursing staff, COVID had a huge impact on our nursing input, because there was only so many nurses. In the UK, there's always a shortage of nurses. So we as pharmacists had to skill up, and our technicians were then pairing up with nurses to make medication for them. So what the nurses would technically do on ITU and HDU, preparing medication, that task was now allocated to pharmacists and pharmacy technicians, because the turnaround was really quick and the nursing needs had increased, and they didn't have the time to prepare all these infusions and boluses. So what we had to do is come up with a smart way of administering all these medications in a timely manner. So we were preparing boluses on ITU and HDU to be given, and we had to research into stability data to see how long they would be stable for within the storage conditions, and then prepare them in advance so we could then administer, the nurses could easily administer these medicines to the patients without having to worry about that bit. So as pharmacists, and pharmacy technicians as well, who play a big role in the pharmacy setup here in the UK hospitals, we took that responsibility over from the nursing team. Also, in terms of medication shortages, I'm sure everybody had a similar situation. Supply chains were disrupted, and we needed critical medicines in ITU, and HDU for these patients, and also generally for other patients, in the outpatient setup. And we had to change our guidelines. We had to think about switching people. We had to come up with smart ways of delivering these medicines in the current context. Luckily, we have bodies that were already in place that were giving us national advice on that platform. So if you look at some websites that I can recommend if you want to learn from them, like SBS, which is a Specialist Pharmacist Services, which is an NHS England initiative that is an information source for a lot of pharmacists, including community pharmacists, where there's a range of clinical guidelines on how to manage conditions, how to switch patients, how to assess patients, and also in terms of the shortages, they would send us memos. Okay, you're short of this. This is what you need to do, and this is what you can use. So that was really useful, with we just did not have the capacity or the facilities to be able to chase those issues individually, and because it was a national issue, it was much more well handled that way. So in terms of clinical practice, I mean, obviously I'm going to divide this into the management of inpatients with COVID is relatively simple if they are not complicated. So it's just supportive treatment with antibiotics and some nebulization and oxygen perhaps. But it was when they were really poorly and the medicines that we were using weren't working that complicated things, and where the ITU and HDU setups came in. And being in the West, we were lucky to have been enrolled on the recovery trial. So the hospital that I worked with was one of the few centers where the recovery trial was done. And as pharmacists, we played a major role in recruiting these patients, because usually we don't get involved because they are small trials, and a lot of trials are done by the clinical trial teams. But this was a massive initiative where everybody needed to get involved. And we had to do a lot of upskilling around the trial, what it was all about, the eligibility. Also, we were using drugs that had a lot of interactions. So we're using drugs like antiretrovirals, lopinavir, ritonavir. We were using hydroxychloroquine. And we were using some, biologics, which also can be quite unsafe if used in the wrong patient population. So as pharmacists, and this was something I was involved with, the trials were, structured, but it was down to the clinicians to make an individual decision based on their experience as to whether a patient was right to be enrolled or eligible and not eligible, because the trial information was quite general and vague. So myself and some of my colleagues and the antimicrobial pharmacist, we had to come up with the eligibility criteria for our clinicians. So we had to factor in things like cautions, indications, comorbidities, and then flag up some significant interactions if the patient was already on certain medication, so that when they were being randomized, they would have a tool that they could use to kind of assess that patient. And if that patient was not eligible for that trial, then we would stop the randomization for that patient at that point. So that, and this prevents medication errors, medication harm, if we were putting this patient at potential danger because of these clinical trial medications, which obviously had narrow therapeutic windows. They were quite potentially serious if you had cardiac problems or metabolic issues. So we got involved in that side of things as well, to help the doctors and the clinical trial team. And then I've already mentioned about remotely screening patients. So Luckily, because we had electronic prescribing, we did not have to be by the patient's bedside to be able to assess their clinical needs. We were able to do that remotely. So if you could be in quarantine because you're suspected of having COVID, but because of our policies and practice, we were able to then work from home and still be able to maintain that continuity in care. The other thing that we were obviously involved with was management of patient medicines that they came in with, so clinical waste management, if I may put it, because when you bring in the UK, most of the UK hospital trusts expect patients to bring in their medicines to save them money, because every time you dispense medication, that's a cost to the hospital. So we always encourage that patients bring in their medicine. But with the COVID situation, obviously, we had to rethink, because if they're going to bring in medicine that's potentially infected, that they've handled, then that can be a risk to our staff, to other patients also, and also in terms of if they're not, if they bring in medication and we infect them on the wards, for example, because they were sharing a ward. We had COVID designated wards, but obviously there were some that were patients are potentially infected and some might not be, and you might be discharged back, but you've actually been in touch with patients who may be infected potentially, and that can infect your belongings, for example, your medicines, if the nurses have handled it. So infection control was a big thing. And as pharmacy, we had to assess all our processes and make sure that if somebody is on a COVID ward, then if they've come in with their medicines, then have they been stored properly? Were they sealed and quarantined properly? If they weren't, and we weren't safe, we weren't sure whether they were okay to go with that medicine back home, then we would have to resupply everything and then quarantine that medicine. So obviously there's a cost implication there, and we had to be very vigilant about how the nurses handle the medicines, because that is a potential risk to other patients and to ourselves as well. We were also involved in clinical, like outpatient clinics, for example, that were pharmacist-led. So we have a number of pharmacist-led clinics like anticoagulation, biologics, dermatology, and we were involved in risk assessing patients. So for patients who are newly going to be started on immunosuppressive drugs or drugs that had narrow therapeutic windows, we had to come up with a criteria to say whether it was appropriate for them to start treatment then, because most of these drugs have a strict monitoring criteria, and monitoring was a big thing that was affected for patients, because especially if you're on high risk medication and you're monitored every month or 3 monthly if you started. During a COVID situation, that just wasn't going to work because we were already stretched. So we had to think of bright ways of, assessing patients again, seeing whether they are eligible to start treatment and how soon does this treatment need to start. And if it wasn't necessary at that point, then we would then defer the patient's treatment to a bit later. And unfortunately, in some cases, we had a lot of patients who are on chemotherapy that couldn't start their patient treatment sooner than they should have. But again, that was a case-by-case decision, and it was all done via telemedicine. So we were lucky that we had some systems in place where the doctors could ring patients and speak to patients, and obviously we had to also manage the supply. So normally for high-risk medication, we would normally give a month's supply and then get the patient in, and then if they needed monitoring, do blood tests and then make the supply. But in some cases, we had to risk assess and say we might need to give you a 3-month supply and monitor you at 3 months, intervals. So we had to put in guidelines, and obviously that can be quite risky if you pick the wrong patient or if you don't follow patients up. So we had to do a lot of safety netting as well, in the sense that we had to let them know that if you have any issues, then this is where you need to go, because potentially a lot of wrong things could happen with the chaos that we had at that point in time. And this was a case with things like warfarin, for example. Patients on warfarin, they needed to come in for more regular monitoring, but we couldn't offer that to the patients because there's a risk if they come into hospital, or if we're even asking them to go to the GP practices who aren't actually working as well as they were, then they wouldn't get that kind of monitoring for their long-term conditions. So we had to consider switching some of these patients to DOACs, so oral, directly acting oral anticoagulants like rivaroxaban, apixaban, whichever was suitable, depending on their comorbidities. But obviously there'd still be some that wouldn't be eligible. So we would have to then still make a plan for those patients. And then with video consultations, we did have a lot of video consultations and telephone consultations, which are great, but they do come with their risks. So for example, we had 1 or 2 medication errors where patients' doses were increased on the phone and they misheard obviously what the doctor was saying. And there was one case where we had an epilepsy patient and they ended up giving their child twice the dose of anti-epilepsy medicine because they misheard the communication. So there's a lot of learning for us. So we had to follow up these patients with written advice. So we had to give both verbal and written to make sure that we reiterate what we'd said, in written advice as well. But generally speaking, most of our outpatient clinics were on telephone or video consultations during the COVID time. And I think it's just now that the rates have gone down and we are now beginning to get patients in to reassess them properly based on their risk again. So if they are a high-risk patient, then we would want to get them in first. And then the ones that probably are low risk or that can wait, we would still ask them to wait. And there's a lot of long wait times as a result. So we are also considering both things that we can recommend home monitoring. So that's another thing that we have had to think about. So patients who can monitor themselves at home, we have had to teach them how to do it so that they can then report back to us. So that is the case for things like isotretinoin, which they use for serious acne. We have a pregnancy prevention program for patients who are on such medication. And normally what used to happen is they used to come into hospital, they used to get a pregnancy test. Then before we would dispense the script, when they into pharmacy, they would come with that result from the clinic. But because they weren't coming into clinic, we had to rely on them to do a pregnancy test at home and then send us a screenshot or a picture of what the test result was. And then we would use that to dispense the prescription and to, the prescribers would use that to write a prescription. So we had to come up with some bright ideas as to how to monitor. And I think the patients that were mostly affected are those patients who are on long-term medication. I think I've spoken quite a bit. I don't know if you have any questions for me. I think that's the gist of, the problems that we have to encounter and what we have to do for our patients to be able to maintain continuity of care. And we still continue to do that because we are still planning for a second wave. And as much as we want continuity to come back, we have to be careful in how we do it. So we still have COVID wards that will be open throughout this season until we have COVID. And then perhaps, depending on how things go, we might think about going back to normal, but this is the new norm. It's not going to change for a bit. We will just have to keep on working on new ways of working to make sure that we can meet the needs of our patients without putting them at risk.
Whereas currently you are saying that the outpatient clinic, you were saying that outpatient clinic during the pandemic was you were connecting to the telephones. Now outpatient, currently now the outpatient wards, how the doctors are or how the pharmacists they're dealing with the outpatient.
So we're having a bit of normality now. Obviously, we still have social distancing when the hospital, when they come in, they have to wear their masks. So with social distancing and it depends whether they need to be seen physically. So where they can do teleconferencing, they're still doing it. But I mean, we are trying to get some normality back. So we do have phased appointments and we are getting to see patients back. So it depends on the clinic. So for example, the surgical clinics, they've started opening because our surgery had just gone down to 0 because we could not afford to have surgical patients in because our ITU services were full. If they needed ITU, HTU after surgery, the capacity was, so we were only doing the urgent surgeries. But now, obviously, we need to work with the backlog and we need to get them in. And sometimes you can only do some things face-to-face because you need to see the patient. So those are the patients we're getting in. And the patients that we feel we don't need to see, we will, send out letters and do it through verbally. So it's all about risk assessment. And we have, if you, I can send you some resources if you're interested. Like I said, SPS, Specialist Pharmacist Services, is very good. We've got all our protocols and all our guidelines as to what, most of these specialities have agreed nationally, in terms of patient care and risk assessment. And that's what we follow. And then obviously we always feed back. If something isn't working, then we will write to them and say, this isn't working for us. And we might have to adapt some protocols locally. But I think by September, the aim is to get 90% of the hospital back to working the way we used to work, because the cases have gone down. We haven't got very many COVID cases at the moment, thank God. So we are hoping that we can now get back to normal because the patients, I think, it's always a risk not seeing a patient, especially for clinical work. So we want to get back to where we used to be, but obviously with the social distancing. So for example, with the prescriptions, we've had to deliver prescriptions because we don't want them to come in for the consultation and then come in again to pick their prescription if the medicine is not in. So we've had to have taxi deliveries, or then we'll try and see if the GP can, get the prescription, because normally they pick from the hospital. But if we are encouraging them not to come in, then we say, can you go to your nearest pharmacy, and we will get the GP to then write the prescription. We're still managing it, but I think we are at this stage where we want some activity to come back.
From your experience, what do you think, which people were more prone to the COVID virus? I mean, in the hospitals, the people who were hospitalized, what do you think? Is the age, what you have experienced?
Certainly, there's been a lot of research. And I think especially in the European countries and in the developed countries where there's loads of cultural differences, there's a diverse community. So diversity is a big thing in the West. And there has been a lot of research. So obviously they say that obviously people with comorbidities, so over 65s or 70s, I'd say, are those with immunosuppressive conditions like rheumatoid arthritis, or on immunosuppressive medicines, those with cardiovascular comorbidities, and also ethnicity. So for us in the UK, British Asian minority ethnicities are known to be high risk. So for example, for me, I was assessed and I had to be given, conditions for work. So for example, I've had to work a lot from home because of my ethnicity, where I can. Where I can't, yes, I would go in, but I'd have to be careful how I work, because they did categorize, the ethnic minority as a high risk. So we've had a lot of focus on, especially in the nursing staff, the doctors who've died, because I think there was a trend that most of the people, medical staff were affected were from the ethnic minority. So we were, risk assessed at work, and we were given, options on how we want to work, so that we can reduce risk for that population. So I think for yourself, especially in Pakistan, because of our genetics and our, our comorbidities, I mean, almost everybody in the Asian population will have some sort of cardiovascular disease, diabetes, and all these kind of reduce your immunity, especially if you've got some kind of endocrine condition that will, especially with diabetes, it does reduce your immunity. So you are obviously, and obesity is another thing, people who are overweight, they are known to have high risk of COVID. So now there's a drive in England where they're promoting weight loss. So obesity and on NHS England is a big agenda at the moment, because they want people to be healthy, because that's also something that has contributed to COVID deaths. So we have a big, drum roll about getting, because the lockdown has had impact on people's health. You aren't able to exercise, you aren't able to go out, and that in itself is a risk factor, because people are put on weight. and we need to get them back to baseline. If you've been working from home, you've not been commuting, you haven't been walking as much, because a lot of people do their day-to-day exercise at work sometimes, walking up the stairs, going to different wards, or walking to work, and you haven't been able to do that, and you've just ended up putting on weight because your lifestyle's changed so much in the few months. So yeah, it's a number of factors that they have raised. And I think one, the ethnic minority, diversity, so poverty is another thing. If you're not eating well, you're low in vitamin D, that, it's a bit controversial, but I think there is some evidence that suggests that if you are deficient in vitamin D, then you're at a risk of developing some of these complications, and COVID-related complications is one of them, because it just reduces your immunity. So a lot of us have been asked to take vitamin D, especially if you are, deficient in it, or then just make sure supplementing if you are in that high risk category, so that you can at least, it's not 100%, but it won't do you harm. So you might as well take it.
Yeah, sure. Yeah, sunlight, in England, I think there's a problem with the sunlight. Even in Pakistan, there are a lot of people with vitamin D deficiency.
Miss Mehnaz, please, I want to ask a very simple and straight question. That is the earlier speaker said that 73% or around above 70% are the field force or the workforce for the pharmacists. How many pharmacists in NHS, what do you think? They are working well, female pharmacists, and they are performing well, and what's the ratio of that? And secondly, what is the priority of the pharmacist to be assigned by the government to do that? Please highlight these.
So to be honest, I'm not sure about the ratio, but pharmacy in England is predominantly women. If you look at my department, we have 70% female pharmacists and 30% male. So predominantly, most of the clinical pharmacists within our trust, at least, and a few trusts that I've worked, pharmacy is a woman-led profession, I would say, in the NHS trust, from the way I see it. In terms of our scope and where we'll sit within the NHS, pharmacy is in the forefront. I am a prescribing pharmacist, so I can prescribe. I prescribe anticoagulation. We are upskilled to that level where we have dedicated ward pharmacists that run a ward with the help of obviously the nurses and doctors. But we are able to order blood tests. We are able to monitor patients. We have clinics that we run as pharmacists. And in my trust, because we have so many prescribing pharmacists, when we are not there, the doctors struggle, because in a way we've spoiled them, because we do everything medication related for them. We will prescribe for them. We will send the blood tests out. We will monitor the patients for them. And when they are getting discharged, we write the discharge letter for the medicines. They do the clinical side. So they will do the investigation, they will write the history in terms of the presenting complaint, but when it comes to medicine, we take over. So when we are not there to give our input, they do feel that something is missing. So the way our service has been designed, at least at our trust, I can say, pharmacists are integrated in every service that we provide, inpatient and outpatient. We are involved with TPN. We do all the trauma and surgical assessment. Patients go through us, where we risk assess their medicines, and we will stop the medicines. And at just before surgery, we will again go through their medicines and then make a plan for them. We do the anticoagulation for DVT, PE, atrial fibrillation. We have a biologics pharmacist who manages the biologics for rheumatology, gastroenterology. So there's a number of services that we offer. So we have an emergency department pharmacist that is responsible for ED, and they also do things like X-rays. So we are trained to even perform X-rays. So that's how advanced you can get as a pharmacist within the UK. It's a massive scope. And now in the community, we have a drive for pharmacists that can do the same. So hospital took the lead, but now in community, we're developing posts where pharmacists are working very closely with GPs, to be able to monitor long-term conditions, write prescriptions for them, and run a clinic where GP is not available. So the GP is only getting to see the very poorly or serious patients, and the pharmacists are seeing the more stable, chronic patients that then they can refer to GPs if they feel that they aren't doing well and they need further intervention. So yeah, as pharmacists, I think clinically we are much involved. The roles are changing so much that we are now also consultant pharmacists in some areas. So we have consultant pharmacists in anticoagulation, in diabetes, that are there are few posts. They're not very many, but they are there, and you can work completely independently and run your practice and just be as efficient as a doctor. Yes, you'd have to work with your colleagues because there's some things based on your experience you might not be able to address, but that's where the teamwork comes in. You then refer that patient to somebody that you feel may be able to give that extra advice.
Thank you very much, Mehnaz, for joining us.
Thank you for having me. Thank you so much.
Nice to see you. Nice to
Same here.
Dr. Saira, the next speaker, please introduce the next speaker.
Yes. Our next speaker is Dr. Mohammad Asim Rana. He is an MBBS doctor and is the head of the critical care services at Beria Hospital in Lahore, where he is currently dealing with the critical patients of COVID-19. He has 5 ICUs, including 2 medical, 1 general surgical, 1 kidney transplant, 1 liver transplant ICU, and shares 1 CCU as well. He has successfully completed more than 100 kidney transplants and 34 liver transplants so far. The medical ICU under his supervision is par excellence and has remarkable track record in the management of medical patients. At Sherwood Forest Hospital NHS Foundation, he was a consultant in acute medicine to provide direct clinical care to the medical patients admitted in the acute medical care unit via emergency. He has also been working at the King South Medical City, where he started as the senior registrar, and it is one of the biggest ICU in the Asia with 140 fully equipped beds. He was promoted as a consultant in ICU in 2013 and was given additional responsibilities of research and publication division, and worked as the head of the internal examination committee for Saudi Fellowship. It's a pleasure to have you with us on board, Dr. Asim. Now over to you. I think there are some connecting issues. Sir, please, can we have you with...
Doctor, please, आप हमें सुन रहे हैं? Are you connected with us?
Hello, can you?
जी.
Hello.
जी. Doctor, अस्सलाम वालेकुम.
Walaikum salam. Can you hear me clearly?
जी.
आपको आवाज आ रही है?
जी थोड़ी सी कम है. आप थोड़ा सा आप a bit loud.
आप कुछ ठीक बोलिए.
जी.
अभी कुछ बेहतर हो गई है. असल में हमारा थोड़ा सा इंटरनेट का थोड़ा ग्लिच आ रहा है इधर बेरिया टाउन में जहाँ से हम लोग काम करें.
जी डॉक्टर साहब, एक्चुअली काफ़ी जगहों पर है ऐसा इशू, बट इट इज़ गोइंग थ्रू. आपकी आवाज़ हमें आ रही है.
ठीक है. थैंक यू वेरी मच फॉर इनवाइटिंग मी. आप सब लोगों को बहुत बहुत हेलो
डॉक्टर, थोड़ा सा ऊंचा बोलें.
जी, मैं का आप सब लोगों का बहुत बहुत शुक्रिया मुझे इनवाइट करने का. शुक्रिया. इंटरनेट ग्लिच की
जी
वजह से
वेलकम डॉक्टर, वेलकम.
Should I start? Hello.
Yes, sir. Please, you can start.
आप जो है वो शेयर स्क्रीन को देखिए थोड़ा आपने डिसेबल किया हुआ है उसको देखिए प्लीज
जी डॉक्टर साहब आपको देखें राइट्स दे दी
इंशाल्लाह मैं देखता हूँ मैंने इसमें अपनी प्रेजेंटेशन ऐड की है
डॉक्टर सायरा प्लीज चेक करें कि क्या हुआ है।
जी वो शेयर स्क्रीन के राइट्स जो है ना वो मैंने जी
जी डॉक्टर साहब ये विजिबल है हम सबको। डॉक्टर सायरा मिस नबीला आप सबको भी विजिबल है? जी आप सबको विजिबल होगा ये स्लाइड?
जी
डॉक्टर साहब प्लीज।
Right. Bismillahirrahmanirrahim. Thank you very much everybody for inviting me in this webinar. आप सब लोग बहुत मेहनत कर रहे हैं, मैं सब लोगों को बहुत ज़्यादा अप्रिशिएट करता हूँ और अपॉलॉजीज के मैं पहले ज्वाइन नहीं कर सका, थोड़ा सा काम का लोड जो है वो मंडेज को आपको बता देता होता है। तो विदाउट एनी डिलेज लेट्स गेट स्टार्टेड। अभी जो मेनली मैं चाहता हूँ कि आप सब लोग फार्मासिस्ट हैं, ऑल ऑफ यू know the pharmacology more than me. So I'll just try to go through a very brief introduction. I hope the whole screen is visible to all of you. We all know that the SARS severe acute respiratory syndrome virus, it attaches itself with the host cell through its spike proteins, and these proteins are called as proteins. Once they enter, they attach themselves to the spike protein. The virus is engulfed by the cell membrane, and once inside the cell, of course, it takes over the cell mechanisms of making the RNA, and it uses all the machinery of the cells to make its own virion particles. And once the particles are made, they are moved out by exostosis. Now, the management plan or treatment plan which all we have been doing actually is trying that we are all trying to get.
डॉक्टर साहब जरा थोड़ा सा ऊंचा बोलें, आवाज नहीं आ रही आपकी। सायरा जरा चेक करें, आवाज नहीं आ रही डॉक्टर साहब की।
अब आ रही है
डॉक्टर सायरा?
कुछ बेहतर हो गई है
जी, अब कुछ बेहतर हुई है, अब कुछ बेहतर हुई है। जी
अच्छा, मैं ये कह रहा था कि देखिए
हाँ डॉक्टर साहब इसी जरा थोड़ा सा बिट अलाउड होंगे तो हमें रिकॉर्डिंग में आसानी भी होगी और आसानी से स्टूडेंट्स एंड द फैकल्टी कुड हियर इट। थैंक यू
वेरी मच। मैं ये कहना चाह रहा था कि आप सब लोग फार्माकोलॉजी के स्टूडेंट्स हैं और टीचर्स हैं, तो फार्माकोलॉजी तो मैं आप लोगों को सारी बातें नहीं पढ़ा सकता, वो तो आप ही बेहतर जानते हैं। मैं ब्रीफली टच करूँगा ये जो वायरस है इसको हम कैसे मैनेज कर रहे हैं, उसकी ट्रीटमेंट में क्यों, कहाँ पे कौन सी मेडिसिन इस्तेमाल होती है, और विल ट्राई टू जस्टिफाई कि हम उसको क्यों यूज़ कर रहे हैं। फर्स्ट ऑफ ऑल वी ऑल मस्ट नो दैट दिस वायरस इज गिवन ए नेम नोवल कोरोना वायरस बिकॉज nobody has seen it before. This disease is altogether new, और तमाम की तमाम दुनिया में ये लोग जो हैं सब के सब वो जो भी इससे मुतासिर हो रहे हैं या जो भी इसको ट्रीट कर रहे हैं वो सब इसको अंडरस्टैंड करने में अभी तक पूरी तरह से कामयाब नहीं होंगे। तो ये एक ब्रीफ सा रिव्यू है। देखिए कि जो स्पाइक प्रोटीन्स हैं कोरोना वायरस की, उसके ज़रिए ये सेल्स के जो एस टू रिसेप्टर्स हैं और TMPRSS2 रिसेप्टर्स हैं, उनके ज़रिए ये अपने आप को अटैच करता है ना जब सेल लाइनिंग के ऊपर, स्पेशली दी रेस्पिरेटरी ट्रैक के जो सेल हैं, तो वहाँ पे एक प्रोसेस शुरू होता है जिससे कि ये एनगल्फ कर लिया जाता है सेल, और इसके इर्द जो है सेल मेम्ब्रेन जो है वो एक एनवेलप बना लेती है। वंस इनसाइड द सेल इट अफेक्ट्स द मशीनरी ऑफ द सेल इटसेल्फ, और वहाँ से ये अपने लिए वायरस के जो विरियन के जो पार्टिकल्स हैं डिफरेंट वो बनवाना शुरू कर देता है। एंड देन वंस वायरस जिस वक्त बन जाता है तो ये वहाँ से एक्सोस्टोसिस किया जाना वो पूछ लेगा। अब आप ये देखें कि जो मेडिसिन हैं जो हम इसके लिए यूज़ करते हैं, वो अगर आप थोड़ा सा इस पिक्चर को ज़हन में रखिए तो आपको अंदाज़ा होगा कि आप इसको यहाँ रोक सकते हैं जिस जगह पे ये वायरस जो है सेल में दाखिल होना चाह रहा है। उसके बाद उसकी मेम्ब्रेन फ्यूजन और एंडोसाइटोसिस जो है वहाँ पे इसको रोका जा सकता है। एंड देन यहाँ पे ये मल्टीप्लिकेशन हो रही है इसकी जो RNA जो है उसकी जहाँ पे जिसे आप कहते हैं ट्रांसक्रिप्टेज जो है वो काम करे, हेलो, वहाँ पे आप इसको रोक सकते हैं। तो अब आप ये देखिए कि हमारे पास जो इसकी ये ब्रीफ सी एक इंट्रोडक्शन है कि जो वायरस सिंगल स्ट्रैंडेड RNA है ये जाता है थ्रू द वायरस स्पाइक प्रोटीन जो है ना एस लिपिड जो एंजियोटेंसिन रिसेप्टर एंजाइम्स हैं उनके ज़रिए, यह भी हमने बात की। और once inside the cell the viral polyproteins are sensitized that encode for the वो उसकी अपनी जो रेप्लिकेट करती हैं ट्रांसक्रिप्टेज प्रोसेस को। ये सारी बात को अगर आप जहन में रखें तो क्विकली अगर हम आपसे बात करें कि ये देखिए फिर उसके बाद क्या हो रहा है कि वंस इनसाइड ये जिस वक्त वो अपने वायरस को के प्रोसेस को एक्टिवेट करता है सेल के अंदर जो है, आप ये देखिए कि प्रॉब्लम एक ये है कि सेल के अंदर एक फॉरेन जो है वो मटेरियल घुसा है। This foreign material or the virions when takes over the cell definitely tries to follow the commands of the virus, but on the same time the cell tries to protect itself. And what happens is कि वहाँ से फिर वो आप यूँ समझ लें कि वो सिग्नल जो है वो भेजना शुरू कर देता है कि समथिंग इज़ हैपनिंग विद मी, जो कि मेरी समझ में नहीं आ रहा। अब वो जो सिग्नल्स हैं वो सिग्नल जब सेल के बाहर जाते हैं तो वो साइटोकाइन केमिकल्स होते हैं जो कि साइटोकाइन स्टॉर्म की सूरत में एक्टिवेट होते हैं, राइट। अब ये जो साइटोकाइन स्टॉर्म है इससे आगे हमारे सारे प्रॉब्लम्स शुरू होते हैं। जहाँ तक इंटेंसिव केयर मैनेजमेंट का ताल्लुक है, जो मैं आपके साथ शेयर करना चाहता हूँ वो ये है कि किसी भी जो अफेक्टेड पेशेंट की मैनेजमेंट है उसके जो एस्पेक्ट्स हैं वो इस तरह से आप डिवाइड कर सकते हैं कि उसमें सबसे पहले आप ये देखिए कि उसको हमने उस वायरस से निजात दिलानी है। वी हैव टू टेक केयर ऑफ दैट वायरस, देन वी हैव टू टेक केयर ऑफ द कोमॉर्बिडिटीज ऑफ द पेशेंट ऑल्सो। पेशेंट्स आर डायबिटिक, दे आर हाइपरटेंसिव, दे हैव इस्केमिक हार्ट डिजीज, एंड देन ऑफ कोर्स ऑन द सेम टाइम वो जो साइटोकाइन सिंड्रोम है, ये साइटोकाइन स्टॉर्म जो रिलीज हो रहा है, यू हैव टू सेटल दैट वन ऑल्सो। अदरवाइज क्या होगा कि इन्फ्लेमेटरी प्रोसेस इतना ज़्यादा हो जाता है कि इट लीड्स टू डैमेज इन द एल्वेलाई, एंड देन द मेन प्रॉब्लम विच वी फेस इज गैस एक्सचेंज। ऑक्सीजन एक्सचेंज नहीं होती एंड द पेशेंट डाइज ऑफ हाइपोक्सिया। आगे आप देखिए कि हमने यहाँ पे दो सेक्शन आपके लिए रखे हैं, ऑक्सीजन और एंटीबायोटिक्स। वी हैव टू गिव देम ऑक्सीजन, right, to combat the hypoxia, and then we sometimes have to give them antibiotics so that if there is any superadded infection उसको भी हम साथ में हैंडल कर सकते हैं। एक मैंने यहाँ पे कंपोनेंट रखा है एंटी कोएगुलेशन का, तो ज़रा गौर कीजिए। मैं एक मिनट के लिए पिछली स्लाइड पे जाऊँगा। व्हाट हैपन्स इज कि जिस वक्त ये साइटोकाइन स्टॉर्म शुरू होता है उस वक्त एक्चुअली कॉम्प्लीमेंट सिस्टम भी एक्टिवेट होता है और उसके साथ साथ जो क्लॉटिंग कैस्केड है वो भी एक्टिवेट है। क्लॉटिंग कैस्केड है वो बहुत ज़्यादा थ्रोम्बाई बनाता है और पूरी की पूरी बॉडी के अंदर एक कोएगुलेशन का सिस्टम शुरू हो जाता है जिसे आप सेप्सिस इंड्यूस्ड कोएगुलोपैथी या SIC कह सकते हैं। it is more like it is similar to somehow जिसे आप DIC कहते हैं, disseminated intravascular coagulation. तो आप देखें कि होता क्या है कि तमाम के तमाम, आई होप यू कैन सी द एरो, जो छोटी स्मॉल ब्लड वेसल्स हैं उनके अंदर सारी की सारी जो है वो क्लॉट हो जाती है, तो बंद होना शुरू होती है बिकॉज ऑफ द हाइपर कोएगुलेबिलिटी, एंड देन एक्चुअली द पेशेंट स्टार्ट सफरिंग. एक तो आप देखिए कि जो उसकी कार्डियक है उसमें होंगी तो पेशेंट को जो है वो माइट्रल इन्फेक्शन या एक्यूट कोरोनरी सिंड्रोम हो सकता है. इसी तरह से किडनी के स्मॉल वेसल्स में जिस वक्त होता है तो पेशेंट सफर्स फ्रॉम एक्यूट किडनी इंजरी. सबसे ज़्यादा प्रॉब्लम होती हैं लंग्स की स्मॉल वेसल में. लंग्स की स्मॉल वेसल में जिस वक्त वो क्लॉटिंग होती है तो दो नुकसान होते हैं. एक नुकसान तो ये होता है कि गैस एक्सचेंज नहीं होती है, दूसरा ये होता है कि वहाँ पे फर्दर इन्फ्लेमेशन जो है वो एक सेटअप हो जाती है. तो आप अगर मैं एक टर्म इस्तेमाल करूँ थ्रोम्बो इन्फ्लेमेटरी रिस्पॉन्स या इम्यूनोथ्रोम्बोसिस, तो आपको थोड़ा सा ये अंडरस्टैंड करने में आसानी होगी कि एक्चुअली द बॉडी इज़ ट्राइंग टू फाइट बैक, लेकिन उस फाइट बैक करने में उल्टा नुकसान हो रहा है और ज़्यादा क्लॉट्स जो हैं वो बनते जा रहे हैं. तो लेट्स सी, जो मैं आपसे बात करना चाह रहा था वो ये है कि एक पेशेंट को जो कोविड-19 से का इन्फेक्टेड पेशेंट है उसके आपको ये सारे के सारे एस्पेक्ट जो है वो मैनेज और डील करने हैं. You have to give them supplemental oxygen so that they can breathe better. लेकिन उसके साथ साथ right on the same time what we need to do is जो उसकी प्रॉब्लम है ना जिसकी वजह से गैस एक्सचेंज नहीं हो रही उसको हैंडल करना है. अब जो गैस एक्सचेंज नहीं हो रही होती वो आप याद रखिए, मैं उसको समरी में कहूँगा कि वो 3 लेवल्स पे प्रॉब्लम हो रही होती है. एक ये हो रहा होता है कि जो pneumocytes हैं, जो कि the cells which are lining the alveoli, they are inflamed, they are swollen up, they are having secretions. The second thing what happens is जिस वक्त वो वहाँ से cytokines रिलीज करते हैं तो हमारे बॉडी के जो प्रोटेक्टेड सेल्स हैं, जो वाइट सेल्स हैं, वो वहाँ तक माइग्रेट करते हैं एंड देन दे स्टार्ट सिक्रेटिंग देयर एंजाइम्स देयर. क्योंकि जिस वक्त वो वहाँ पे आते हैं एल्वेओलाई में, वो सिग्नल्स की वजह से कि जो सिग्नल्स उनको न्यूमोसाइट्स ने भेजे हैं कि भी देयर इज समथिंग व्हिच इज़ डैमेजिंग अस, तो हमें आके बचाओ. अब वाइट सेल उनको बचाने के लिए आ तो जाते हैं, लेकिन उस वक्त आके वो जो है वहाँ पे क्या करेंगे, उनको वायरस तो नज़र नहीं आता. So what they do is they start secreting their chemicals there all around. कि जी वो जिससे आप यूँ समझ लें कि वो एक अंधाधुंध फायरिंग जो है वहाँ शुरू हो जाए और उस अंधाधुंध फायरिंग से एल्वेओलस के अंदर इन्फ्लेमेटरी फ्लूइड भर जाता है. दिस इन्फ्लेमेटरी फ्लूइड्स हैम्पर्स द gas exchange further, and then on top of that what happens is the small blood vessels they get occluded. So what happens, gas cannot pass from the alveolus to the blood vessel and the patient suffers from hypoxia. Unfortunately, the virus also affects the brainstem of the patient and our respiratory center gets affected. आप लोगों ने एक टर्म सुनी होगी हैप्पी हाइपोक्सिया. अब हैप्पी हाइपोक्सिया असल में क्या होता है कि जब हम पेशेंट देखते हैं उसकी सैचुरेशन बहुत कम होती है. जब सैचुरेशन उसकी होती है लाइक 70s में या 75, 80s में, अब पेशेंट आराम से बैठा होता है. आप कहते हैं भाई आपको सांस आ रहा है, वो कहते हैं कि मुझे कोई मसला ही नहीं है, जबकि आप नंबर्स देख के परेशान हैं. सो दिस इज़ व्हाट इज़ हैपनिंग इनसाइड ए पेशेंट. सो व्हाट वी डू इज़ वी स्टार्ट गिविंग देम antivirals so that we can kill the virus. We start treating their comorbidities and then we start giving them steroids. And I have used a word here, you can see TOCI, T-O-C-I. TOCI is actually an abbreviation of tocilizumab. Tocilizumab is an interleukin-6 inhibitor. So what happens is, inside a COVID-19 affected cell, a lot of inflammatory fluids and inflammatory molecules are secreted. Tocilizumab has proven to help by stopping that storm. Let's see how the things help us. I was just trying to see how far we have tried to do some research on this disease. Yesterday I found that there has been 3,009 studies registered already under the name of COVID-19. So just expect that 3009 trials have been registered in this clinical trials website. So gradually the results will start coming. At the moment, we only have received preliminary results of 2 trials which have actually changed the treatment so far. One of them was the recovery trial, which was on the dexamethasone, and the other was the remdesivir. So I'll briefly touch these things. Uh, Once again, the thing which I want you to understand is when this disease started, remember, initially in the China, they thought it is influenza. But what was happening that the patients started to die rapidly, which actually they were afraid or they were surprised to see क्या हो रहा है कि patient एकदम से मरना क्यों शुरू हो गए, until they isolated the virus कि ये तो influenza virus नहीं है, this is something else. So then they identified the virus as the coronavirus strain. अब वो कोरोना वायरस फैमिली में से जब उन्होंने इसको देखा तो ऑटोमेटिकली आप देखें कि एक डी रिफ्लेक्स है कि पहले हम जो भी वायरसेस में मेडिसिन इस्तेमाल करते रहे हैं, लाइक इन दिस चाइना का जो सार्स था, सीवियर एक्यूट रेस्पिरेटरी सिंड्रोम वायरस था, या मिडिल ईस्ट रेस्पिरेटरी सिंड्रोम वायरस था, उसके ऊपर आई हैव सीन द प्रीवियस 2 एपिडेमिक्स जिसमें कि हमने अगर आपको याद हो स्वाइन फ्लू था 2009 में, स्वाइन फ्लू भी हम लोगों ने हैंडल किया। उसके बाद मैं उस वक्त मिडिल ईस्ट में काम करता था जब मिडिल ईस्ट रेस्पिरेटरी सिंड्रोम स्टार्ट हुआ, तो मिडिल ईस्ट रेस्पिरेटरी सिंड्रोम भी हम लोगों ने वहाँ पे हैंडल किया। तो आप ये देखें कि कोई भी फिजिशियन जब ट्रीट करना शुरू करेगा तो उसका ना एक ऑटोमेटिक रिफ्लेक्स बन जाएगा कि ये तो वही पुराने वाला वायरस है, तो वो पुरानी दवाइयाँ शुरू करनी शुरू कर देगा, राइट। तो इसलिए मैंने ये लफ्ज़ इस्तेमाल किया है रिव्यू ऑफ द सिलेक्टेड रीपर्पोज ड्रग। रीपर्पोज का मतलब ये है कि ये वो मेडिसिन हैं जो कि पहले यूज़ की जाती रही हैं इन दी प्रीवियस एपिडेमिक्स। तो द थिंग इज़ जो कि ज़रूरी है समझना कि उनके भी जो रिजल्ट्स थे वो अभी तक इतने क्लियर नहीं है। सो फार हमें कोई भी उसकी स्पेसिफिक रिजीम नहीं मिली, लेकिन हुआ ये है कि इन विट्रो एक्टिविटीज़ उनकी देखते के ना तो वो पब्लिश होती जा रही है कि ये भी वायरस दवाई काम कर रही है, ये भी दवाई काम कर रही है। तो व्हाट हैपेंड इन वुहान, दे ट्राइड यूजिंग ऑल दोज मेडिसिन। तो सबसे पहले जो उसमें मेडिसिन उन्होंने इस्तेमाल की वो थी क्लोरोक्विन एंड हाइड्रोक्सीक्लोरोक्विन। अब इस दवाई के ऊपर अब तक बहुत सारी बातें कही जा चुकी हैं, सुनी जा चुकी है। यूनाइटेड स्टेट्स में इसके ऊपर बहुत सारी आपने देखा होगा वीडियोज़ भी बनी है कि वो अस्पतालों में डॉक्टर कह रहे हैं कि हाइड्रोक्सीक्लोरोक्विन इस्तेमाल करनी चाहिए और FDA ने उसको हटा दिया है। इसमें कोई कॉन्स्पिरेसी थ्योरी भी प्रपोज की जा रही है। आई विल नॉट गो इनटू द डिटेल्स ऑफ दैट। मैं सिर्फ आपको ये बताना चाहूँगा कि व्हाई डू वी यूज़ हाइड्रोक्सीक्लोरोक्विन और क्लोरोक्विन। Actually, they appear to block the viral entry into the cells by inhibiting the glycosylation of the host receptor. So the proteolytic process जिसके ज़रिए वो उसको engulf करता है ना वायरस को, वो रुक जाता है। तो actually it is not an antiviral, ये सिर्फ होस्ट के अंदर वायरस की एंट्री को रोकता है। जब वायरस की एंट्री को जब रोक देंगे तो फर्दर वो जो सारा कैस्केड है एक इन्फ्लेमेशन का वो शुरू नहीं होगा। इट विल नॉट क्लियर द वायरस इटसेल्फ। ये बात थोड़ी सी समझने वाली है। सिर्फ ये है कि लोग ये समझते हैं कि हाइड्रोक्सीक्लोरोक्विन अगर हम देंगे तो पेशेंट जो है वो ठीक हो जाएगा। एक्चुअली ऐसा नहीं है। सिर्फ थोड़ी सी बात ये याद रखें कि ये हाइड्रोक्सीक्लोरोक्विन इस्तेमाल करेंगे तो पेशेंट की इन्फेक्शन स्प्रेड नहीं करेगी, वर्स नहीं होगी। उसके अगर वायरसेस वहाँ पे रेस्पिरेटरी ट्रैक में हैं तो वो इनगल्फ नहीं होंगे, वहाँ से वो रुक जाएंगे। और जो आपके लिए मैं टर्म इस्तेमाल करूँगा वायरल लोड जो है, वायरल लोड फिर ज़्यादा कम हो जाएगा। तो एक्चुअली एक तो ये है। दूसरा थोड़ा सा ये याद रखिए कि इनका जो है इम्यूनोमॉड्यूलेटरी इफेक्ट भी है। अब हम लोगों ने भी शुरू में जिस वक्त ये पाकिस्तान में वायरस स्टार्ट हुआ, वी एक्चुअली स्टार्टेड यूजिंग द हाइड्रोक्सीक्लोरोक्विन। और ऑनेस्टली स्पीकिंग बिकॉज वी वर गिविंग ए फुल फ्लेज एक पूरी रजीम देते हैं ना, तो आप आइडेंटिफाई नहीं कर सकते कि हाइड्रोक्सीक्लोरोक्विन आपका कितने काम आ रही है आइडियली, बिकॉज यू हैव एन इंटेंशन टू ट्रीट। आप किसी भी पेशेंट को रिस्क पे नहीं छोड़ सकते कि इसको मैं सिर्फ हाइड्रोक्सीक्लोरोक्विन दूँ और दूसरे पेशेंट को मैं हाइड्रोक्सीक्लोरोक्विन के अलावा दूसरी ड्रग्स जो कि मुझे पता है कि फ़ायदा देंगी मैं वो दूँ। आर यू विद मी? सो व्हाट हैपेंस इज वी कुड नॉट डू क्लियर हेड टू हेड ट्रायल्स ऑफ हाइड्रोक्सीक्लोरोक्विन। खुद हमारा अपना जो हाइड्रोक्सीक्लोरोक्विन का ट्रायल है हमने बीच में रोक दिया अपना बहरी हॉस्पिटल का। सो वी गेव हाइड्रोक्सीक्लोरोक्विन टू सम लाइक 32 पेशेंट्स, वी गॉट सम गुड रिजल्ट्स। लेकिन अभी तक हम खुद भी उसमें बाइस्ड हैं कि वो सिर्फ हाइड्रोक्सीक्लोरोक्विन की वजह से है या साथ में जो दूसरी एडजक्टिव थेरेपी हम दे रहे थे उसकी वजह से। तो आप ये देखिए कि जो डोजेज इसकी है वो असल में इन विट्रो जो हमने देखा है कि क्लोरोक्विन इनहिबिट्स द SARS-CoV-2 इन विट्रो विद ए हाफ मैक्सिमल इफेक्ट कंसंट्रेशन EC50। ये आप लोगों का बड़ा फेवरेट जो है ये पॉइंट है। तो उसमें बड़ी लो माइक्रोमोलर रेंज में जो है वो हाइड्रोक्सीक्लोरोक्विन जो है और क्लोरोक्विन काम करती है। तो उसकी जो डोजेज अब तक प्रपोज की गई हैं वो जो है वो ये है कि क्लोरोक्विन जो है वो आप देते हैं 500 मिलीग्राम ओरली वंस और ट्वाइस डेली, जबकि हाइड्रोक्सीक्लोरोक्विन की जो ऑप्टिमल डोज है दैट इज 400 मिलीग्राम ट्वाइस डेली फॉर अ डे एंड देन वी गिव देम 200 मिलीग्राम ट्वाइस डेली। We actually tried giving them 400 milligram twice daily, and our focus was whether they can cause the side effects or no. So, you know, hydroxychloroquine and chloroquine, they are relatively safe drugs. We have been using them in rheumatoid arthritis, we've been using them in SLE and other connective tissue diseases since long time. थोड़ा बहुत जो उनके साथ प्रॉब्लम होती है वो है, एक तो क्यूटी प्रोलॉन्ग होता है, दूसरा हाइपोग्लाइसीमिया और तीसरा आईज को अफेक्ट करती है, बट लेकिन वो भी प्रोलॉन्ग यूज़ के साथ। यहाँ पे शॉर्ट टर्म के लिए आपने देनी है, शॉर्ट टर्म like 14 days you are giving them in quite good amount of dose for 14 days. So I personally tried to collect some data and we did not find any effect on the QT prolongation. None of our patients developed hypoglycemia. और वही बात मैं यहाँ पे कहूँगा कि actually what happened was those patients were on steroids also, और steroids की वजह से उनको hyperglycemia हो रहा था। तो you cannot identify that the patient is having hypoglycemia or no. तो इसलिए यहाँ पे क्लियर जिसे कहते हैं ना हेड टू हेड ट्रायल्स वो आप इसके ऊपर नहीं कर सकते। फिर उसके बाद एकदम से जो है वो गवर्नमेंट ने इसको बना कर दिया, हमें पंजाब गवर्नमेंट की तरफ से लेटर आ गया कि आपने हाइड्रोक्सीक्लोरोक्विन और क्लोरोक्विन इस्तेमाल नहीं करनी। सो आवर हॉस्पिटल सेड वी डू नॉट यूज दैट वन, सो वी स्टॉप्ड इट देयर। लेकिन अभी डेटा हमारे पास है एंड वी आर ट्राइंग टू एनालाइज इट एंड होपफुली जल्दी जो है ना वो ये आपको इस पर मिलेगा डेटा। उसके बाद ये जो लुपिनावीर और रिटोनावीर है, कलेट्रा के नाम से अवेलेबल है, ये असल में एंटी HIV मेडिसिन है, यू ऑल नो दैट। अब इसमें आइडिया ये है कि बिकॉज हमारा जो कोरोना वायरस है ये एक रीट्रो वायरस है, रिवर्स ट्रांसक्रिप्टेज के जरिए ये, तो वो ये वाली जो है ये भी वो रीट्रो वायरस के अगेंस्ट मेडिसिन है, क्या ये उसके अगेंस्ट काम कर सकती है या नहीं। तो शुरू में लुपिनावीर और रिटोनावीर यूज़ की गई थी और FDA ने इनको प्रूव भी किया, लेकिन अभी तक कोई जिसे कहते हैं ना तसल्ली बख्श रिजल्ट्स, we have not yet been able to find very good results of these two drugs, and they are also not given alone. They are given usually with other medicines like ribavirin, or sometimes they are using them with interferon beta. So we have not yet tried ourselves. The reason being, यहाँ पे पाकिस्तान में ये जो ड्रग्स हैं ये आती हैं WHO के एड्स कंट्रोल प्रोग्राम के अंदर। तो हमें WHO के एड्स कंट्रोल प्रोग्राम में से बल्क में मेडिसिन लेके कोरोना के लिए इस्तेमाल करने की परमिशन नहीं मिल सकी। सो वी कुडंट यूज द लुपिनावीर रिटोनावीर मेडिसिन in our patients. So that is why I'm really not able to share my experiences with you. उसके बाद आप देखिए कि रिबाविरिन एक ड्रग है जो कि हेप सी के लिए इस्तेमाल होती है, हेपेटाइटिस सी के लिए। ये भी वायरल डिपेंडेंट जो पॉलीमरेज है उसको इनहिबिट करती है और रिवर्स ट्रांसक्रिप्टेज प्रोसेस को रोकती है। रिबाविरिन को हमने किसी हद तक यूज़ किया है, बट व्हाट हैपेंस इज एक्चुअली अलोन रिबाविरिन इज ए वीक एंटीवायरल। हमने कुछ पेशेंट्स को दी तो उसका जो वायरस क्लियरेंस का जो डेटा है वो अभी हम उसके ऊपर एनालाइज कर रहे हैं, वो बहुत ज़्यादा सेटिस्फैक्ट्री नहीं है। बट एक्चुअली पीपल हैव यूज्ड, अगर आपको मैं ये अगली स्लाइड दिखाऊं तो पीपल हैव यूज्ड अदर लाइक इंटरफेरॉन अल्फा और बीटा के साथ उन्होंने रिबाविरिन को मिला के दिया। तो मेरे एक कुलीग हैं, वो दे वर टेलिंग दैट हमने काफ़ी अच्छे रिजल्ट हासिल किए हैं विद इंटरफेरॉन बीटा एंड रिबाविरिन, और उन्होंने किसी तरह से लोपिनाविर और रिटोनाविर भी थोड़ी सी हासिल की थी, और उन्होंने उसके साथ भी इंटरफेरॉन बीटा मिला दी। लेकिन अलोन रिबाविरिन को बहुत ज़्यादा खातिर खा आपको फ़ायदा जो है उसने नहीं दिया, लेकिन इसकी जो टॉक्सिसिटी है वो भी हमें देखने में नहीं मिली। 32 पेशेंट्स के करीब हमने रिबाविरिन इस्तेमाल की है। वी आर एट द मोमेंट एनालाइजिंग द डेटा, एंड आई होप that I will share that with you people in coming few days. I can give them to Dr. Bazarul, and she can then share it with you. जो इंटरेस्टिंग रिजल्ट्स हमें मिले हैं ना सारे। अच्छा, ओसेल्टामिविर के बारे में मैं आपको एक बता दूं, ये बड़ी इंटरेस्टिंग बात ये रही है। ये है इट वाज यूज्ड इन 2009, जिस वक्त स्वाइन फ्लू आया था ना, उस वक्त हमने ये बहुत ज़्यादा इस्तेमाल की, और पर्सनली हमें इसके को बहुत अच्छे इफेक्ट उस वक्त भी नहीं मिले थे। लेकिन इनिशियली ये स्टार्ट की चाइना ने, बट देन दे फाउंड दैट इट इज़ यूजलेस, इट इज़ एब्सोल्युटली नॉट वर्किंग अगेंस्ट कोविड, कोरोना का जो वायरस उसके अगेंस्ट था, तो इट हैज़ बीन टेकन आउट ऑफ द ट्रीटमेंट प्लान। उसके बाद आप ये देखिए कि यहाँ पे हमने एक दवाई लिखी है नीटाजॉक्सानाइड और आइवरमेक्टिन, ये जो है एंथ्रालमेंटिक्स है। दे आर हैविंग सम एंटीवायरल एक्टिविटीज इन विट्रो अगेन। अच्छा, अब विट्रो और वीवो की आप सब लोग बेहतर जानते हैं कि जो डोजेजेस हैं वो, और स्पेशली एक पेशेंट जो कि क्रिटिकली सिक है, जिसकी हीमोडायनामिक्स भी मुतासर हो गई हैं, जिसके लिवर और किडनी भी उस तरह से काम नहीं कर रहे, उसकी सेम डोज क्या काम करेगी, सेम डोज उसकी जो मिनिमल इनहिबिटरी कॉन्सेंट्रेशन अचीव कर सकेगी, नहीं कर सकेगी। फिर कुछ इंटरेस्टिंग बात, एक बात और जो अक्सर लोग भूल जाते हैं, वो ये कि अब आपका एक पेशेंट है, क्रिटिकली सिक है, और उसको हो गई है किडनी इंजरी, राइट? आपने उसको एक ट्रीटमेंट स्टार्ट कराई अपनी बेस्ट नॉलेज और उसके मुताबिक। आफ्टरनून में डॉक्टर आसिम साहब राउंड करने आए, डॉक्टर आसिम साहब ने देखा जी इसकी तो किडनी ठीक नहीं है, वो उन्होंने उसको CRRT स्टार्ट करी, राइट? अब इस पेशेंट को 3 दिन के लिए या 4 दिन के लिए कॉन्टिन्यूस रीनल रिप्लेसमेंट थेरेपी मिलनी शुरू होगी। डोज वही है जो डॉक्टर बागा ने या डॉक्टर सायरा ने या किसी ने उसको लिखी थी। अब वो कैन यू इमेजिन कि वो काम करेगी? नहीं करेगी ना, बिकॉज वो जितनी डोज आप उसको दे रहे हैं वो मैं वॉश किए जा रहा हूँ, निकाली जा रहा हूँ, और कॉन्स्टेंटली निकाली जा रहा हूँ। सो देयर दिस इज ए, बल्कि आई वुड रादर सजेस्ट देयर इज a room for research in this side of the critically sick patient, that the dosages should be reviewed, especially for those patients who are having continuous renal replacement therapy. Somehow किसी हद तक जो पेशेंट्स होते हैं ना इंटरमिटेंट हीमोडायलिसिस के, उनके डोजेज जो है वो हम फिर भी रीसेट कर लेते हैं, क्योंकि हमें पता होता है कि जब तक डायलिसिस नहीं होगा तब तक तो ये ब्लड में फिरती रहेगी। जिस दिन डायलिसिस होगा उसमें पोस्ट डायलिसिस हमने उसको बूस्टर दे देना या एक थोड़ी एक्स्ट्रा डोज दे देना। बट द फिजियोलॉजी ऑफ स्पॉन्टेनियस रीनल रिप्लेसमेंट थेरेपी इज ऑल टुगेदर डिफरेंट, राइट? तो एनी हाउ, अब हमने यहाँ पे ये देखा कि आइवरमेक्टिन जो है, इसकी जो डोज विट्रो में आप लोग बताते हैं ना कि ये यूज़ की जा सकती है, ये डोज इन वीवो जो है वो एक तो इतनी इफेक्टिव नहीं है। वीवो के लिए व्हेन वी हैड टू गो एट हायर डोजेज, तो पेशेंट्स को न्यूरोटॉक्सिसिटी जो है वो होनी शुरू हुई। तो इसका भी जो ट्रायल है, या जो कह लें कि जो डेटा है, वो हमें बीच में जो है वो उसको कम करनी पड़ी डोज दोबारा, एंड इवेंचुअली वी केम अप कि ये भी उतनी ज़्यादा इफेक्टिव नहीं है। शुरू में हमें बड़ा लगा था कि वी फाउंड ए ड्रग जो कि पाकिस्तान में है, जो सस्ती है, और वी विल गिव ओनली 4-5 डोजेज एंड विल गेट रिड ऑफ द वायरस, तो वो नहीं हो सका। इसी तरह से ये कॉमस्टेट मिसाइलेट वगैरह जो है, ये सेल एंट्री पे काम करते हैं, लेकिन दीज आर नॉट अवेलेबल इन पाकिस्तान। तो हमारे पास जो मेनली इन्वेस्टिगेशनल ड्रग्स हैं ना, जिनके ऊपर हमने भी काम किया और जो इंटरनेशनली भी काम हुआ, उसमें आप देखिए कि मेनली जो दवाई है वो रेमडेसिविर है। रेमडेसिविर इज़ ए मोनोफॉस्फेट प्रो ड्रग है, जो कि पहले एक्टिवेट होती है इनटू एन एक्टिव सी एडेनोसिन न्यूक्लियोसाइड, एंड देन इट वर्क्स अगेंस्ट दी RNA वायरसेस। और कोरोना वायरस में और फ्लेवी वायरस में जो है ना, इसने काफ़ी ज़्यादा इफेक्ट। अभी जो डोज इसकी रिकमेंडेड है, आप लोगों ने पिछले दिनों देखा होगा डॉक्टर फौची के ऊपर काफ़ी ज़्यादा इस पे क्वेश्चंस भी किए जा रहे हैं और बहुत सारे उसके सर्टिफिकेट भी चीज़ें हैं। The current dose under investigation is a single 200 milligram loading dose and followed by 100 milligram daily infusion. हमने भी यहाँ पे 11 दिन तक ये 10 दिन तक जो है ये डोज दी है, यानी पहले दिन 200 मिलीग्राम, उसके बाद 100 मिलीग्राम डेली। somehow अगेन द प्रॉब्लम इज कि ये दवाई पाकिस्तान में उस वक्त आई है जिस वक्त जो जोर है वायरस का वो टूट गया हुआ है। तो हमारे पास लास्ट मेरा ख्याल है 36 के करीब पेशेंट्स हैं जिनको हमने रेमडेसिविर दी है। अच्छा, इंटरेस्टिंगली वही बात आ जाती है कि कुछ पेशेंट्स में वायरस क्लियर हो गया, लाइक इन 1 वीक और इन 10 days, but there are patients in which we have given repeated doses of remdesivir and they are still positive. I have a patient who is the father of one of my colleague pediatrician. He is positive for the last 6 weeks now. We have given him remdesivir twice. So there are still, the results are dubious still regarding the remdesivir. अगर हम ये देख लें, अगर आप ये देखें कि इसके साथ एक दवाई और है फेविपिरावीर, जापान में इसके ऊपर बहुत सारा काम हो रहा है और रशिया में। फेविपिरावीर जो है इट इज़ ऑल्सो ए प्रोड्रग और ए प्यूरिन न्यूक्लियोटाइड, लेकिन अभी पाकिस्तान में ये रिसेंटली आई है। अभी हमने इसको बहुत ज़्यादा इस्तेमाल इसलिए नहीं किया कि पाकिस्तान की जो हमारी जो गाइडलाइंस हैं वो मेनली जो हेल्थ केयर कमीशन या हमारी जो मिनिस्ट्री ऑफ हेल्थ की तरफ से आ रही है उसमें उन्होंने फेविपिरावीर को भी इंक्लूड नहीं किया है। हाँ, ट्रायल बेसिस पे हम लोग कुछ कर रहे थे इकट्ठा, लेकिन अगेन एट द मोमेंट वी आर, आई वुड से वी आर लकी that the number of COVID patients have reduced drastically, alhamdulillah, summa alhamdulillah, and we have not yet been able to give a trial to this one. एक ट्रायल हम लोगों ने किया है, ये जो एडजंक्टिव थेरेपीज हैं इसके ऊपर मैं थोड़ी सी आप लोगों से ज़्यादा करूँगा कि ये असल में जो मेरा एक्सपीरियंस है, वी हैव सीन अराउंड 160 वेरी सिक पेशेंट्स, जैसे ICU के पेशेंट्स आप कहते हैं ना, and we have used corticosteroids and tocilizumab, ये जो एंटीसाइटोकाइन हैं, and they have proved to be excellent drugs. I would say हमारे बहुत सारे पेशेंट्स जो हैं लास्ट में आके हमने 30 पेशेंट्स को 35 पेशेंट्स को रेमडेसिविर दिए। इससे पहले जो पेशेंट्स हमारे ठीक होके गए हैं वो बेसिकली ये कॉर्टिकोस्टेरॉइड्स और ये जो एंटीसाइटोकाइंस हमने इस्तेमाल किए उससे ठीक हुए। So I am really very big fan of these two drugs. I have not yet been able to convince myself कि हर एक को रेमडेसिविर दिया। जैसे मैंने अभी आपसे बात की, मेरे 2-3 पेशेंट्स ऐसे हैं जिनको रेमडेसिविर ने फ़ायदा नहीं दिया। तो आप ये देखिए कि टोसिलिजुमैब जो है इट्स अ मोनोक्लोनल एंटीबॉडी, इंटरल्यूकिन 6 रिसेप्टर एंटागोनिस्ट है और FDA ने इसको प्रूव एक्चुअली किया था रूमेटॉइड आर्थराइटिस के लिए और साइटोकाइन रिलीज सिंड्रोम। What we do here in ICU is that we daily check some of the inflammatory markers of our patients, like we check CRP, we check D-dimers, we check their ferritin levels, and we calculate their neutrophils and lymphocytes, and then we see the NLR ratio, neutrophils to lymphocyte ratios, and similarly on the same time we check their PF ratios, the oxygen requirement and their partial pressure of oxygen. तो वहाँ से हमने एक स्कोर बनाया हुआ है कि इस पेशेंट को हमने साइटोकाइन सिंड्रोम, साइटोकाइन रिलीज सिंड्रोम पे कैलकुलेट करना है या नहीं करना। इफ़ दैट पेशेंट टचेस दैट लेवल उसको हम टोसिलिजुमैब देते हैं। आप ये देखिए कि मैंने टोसिलिजुमैब हम लोगों ने कोई 80 से ज़्यादा पेशेंट्स को दी है सक्सेसफुली। शुरू में इफ़ यू रिमेंबर तकरीबन ये बात है मई में टोसिलिजुमैब बहुत महंगी मिलती होती थी लाहौर में, लोगों को मिलती नहीं थी, लोग 6-6 लाख रुपए का एक टीका लेकर आते थे। और वो काम भी नहीं करता था। उसकी वजह बाद में हमें ये समझ आई कि हर बंदा जिसके हाथ में इंजेक्शन आ जाता था वो लेके उसको गायब हो जाता था, वो उसको बेचता था हाई प्राइस पे, लेकिन वो अपनी गाड़ी के बूट में रख के ना उसको फिरता रहता था, डिक्की में रख के उसको फिरता रहता था, तो उसकी तो वो कोल्ड चेन ही मेंटेन नहीं होती थी। अब दूसरे लोग जो है अपनी माँ को बचाने के लिए या अपने बच्चे को बचाने के लिए वो अपनी गाड़ी बेच के वो टीका खरीद के लाते थे, एंड दे यूज्ड टू फेल। बट देन रियली वी सडनली फाउंड कि ये टीके जो हैं इनके टेम्परेचर मेंटेन नहीं है, जिसके बाद हमने थोड़ा सा स्ट्रिक्ट एक्शन लिया। तो उसके बाद वी फाउंड मार्वलस रिजल्ट्स। आप यकीन करें 300 350 CRP और फेरेटिन 700 पे 800 पे आप इसलिए जो मैप लगाते थे 3 दिन के अंदर अंदर जो है इन्फ्लेमेटरी मार्कर सेटल डाउन हो जाते थे, गैस एक्सचेंज बेहतर हो जाती थी। सो अभी रिसेंटली मैं पढ़ रहा था कि टुसिलिजुमैब के जो ट्रायल्स हैं, ये मैंने यहाँ नंबर भी दिया हुआ है आपको स्लाइड के ऊपर, ट्रायल नंबर दिया हुआ है, उसमें कुछ इतने ज़्यादा अच्छे रिजल्ट्स नहीं उनको मिले। रॉश इसको स्पॉन्सर करी है, जिनकी ये दवाई है, रॉश एक्टेमरा के नाम से टुसिलिजुमैब बनाती है, लेकिन जो हमारा रिजल्ट है वो बड़ा अच्छा रहा है। हमें टुसिलिजुमैब के ऊपर बहुत ज़्यादा कॉन्फिडेंस है और बहुत ज़्यादा उससे हमें फायदा हुआ। आगे देखिए जो ये दो और एंटी मोनोक्लोनल जो हैं वो एंटीबॉडीज़ हैं, इसमें एक सेरिलुमैब है और बेवासिजुमैब है। इनके ये ट्रायल नंबर्स मैंने आपके लिए लिख दिए हैं। मैं ये जो स्लाइड्स हैं ये सारी आप लोगों के साथ शेयर कर लूँगा, आप इनको जिसको भी कॉपी करनी हो वो इसको कॉपी करे, और ये जो ट्रायल्स हैं इनको आप लोग फॉलो कर सकते हैं कि इनका क्या रिजल्ट बना। अभी ये सारे के सारे ट्रायल जो हैं अभी अपनी वो सेकंड और थर्ड फेज में हैं। अच्छा, ये जो इम्यूनोग्लोबुलिन थेरेपी है, दिस to the best of my practical knowledge, this had been a failure. People had turned bad, they were running after plasma immunoglobulin कि जी हम इसको दे दें। मैं एक छोटी सी आप लोगों की चाहूँगा तवज्जो से मेरी बात सुनिए। इम्यूनोग्लोबुलिन थेरेपी क्या है? इम्यूनोग्लोबुलिन थेरेपी ये है कि आप ये सपोज करते हैं कि एक पेशेंट जिसको एक डिजीज़ हुई उसने उसके खिलाफ एंटीबॉडीज़ बना दी, राइट? अब एंटीबॉडीज़ जब उसने बना ली, वो आप उसकी बनी बनाई एंटीबॉडीज़ लेके तो जो सिक पेशेंट है उसको दे दे। इट्स अ काइंड ऑफ पैसिव इम्यूनिटी, राइट? कि उसको बनी बनाई एंटीबॉडीज़ मिल जाएं और वो उसके अंदर वायरस का खात्मा करें। अब आप ज़रा गौर कीजिए कि जो इम्यूनोग्लोबुलिन्स हैं IVIG जो कि बनी बनाई हैं, ये तो बनी होती हैं और डिजीज़ के लिए। ये वायरस जो कोरोना वायरस है उसके अगेंस्ट कैसे काम करेंगे? बात समझ आती है ना, लॉजिक नहीं है। तो पीपल हु हैव यूज्ड इम्यूनोग्लोबुलिन 3 मिलियन से लेके 4 मिलियन तक का खर्चा आता है इसके ऊपर, एंड यू आर शूटिंग इन डार्क। अगर वो उसको वायरस को कवर करेगी नहीं करेगी, एक्चुअली होता क्या है, आई वुड रादर टेक दिस लिबर्टी ऑफ योर फोरम टू टेल कि एक्चुअली होता ये है कि वो जो इम्यूनोग्लोबुलिन आप लगाते हैं पेशेंट को, वो उसकी दूसरी जो इन्फ्लेमेटरी मार्कर्स बड़े होते हैं ना, वो उनको पकड़ लेके जाके और उनको वो कम कर देती है। तो पेशेंट क्लिनिकली थोड़ा सा इम्प्रूव आपको लगता है कि हो गया, ठीक है। सेप्सिस में भी जो इम्यूनोग्लोबुलिन थेरेपी का रोल है, जिसे पेंटाग्लोबुलिन के नाम से पाकिस्तान में प्रमोट किया जाता है, वो भी यही है कि वो जो इन्फ्लेमेशन उसका जो कैस्केड है उसको जाके ये ब्रेक डाउन कर दे और वो जो सारे जो इन्फ्लेमेटरी साइटोकाइंस हैं उनको वो फिल्टर कर ले। लेकिन पर से एंटीवायरल के तौर पे ये काम नहीं करती। और इसमें भी वही बात आ जाती है कि एक बात याद रखिए कि सारी की सारी हमारी जो नॉलेज है वो पिछले हमारे इन्फ्लुएंजा जो ब्रेकआउट्स हैं ना उस पर डिपेंड करें। तो इन्फ्लुएंजा के ब्रेकआउट्स में हमने ये देखा था कि अगर ऐसे पेशेंट जिनको पहले इन्फ्लुएंजा होकर ठीक हो गया हो, उनका सीरम आप दूसरे इन्फ्लुएंजा के पेशेंट्स को दें तो वो जल्दी इम्प्रूव कर जाते हैं। लेकिन एक बात याद रखिए that the benefit of this therapy would occur primarily within the first 7 to 10 days। जिस वक्त के वायरस रेप्लिकेट कर रहा है, यूजुअली हमारी अंडरस्टैंडिंग जो डिजीज़ की है वो थोड़ी सी मैंने देखा है इवन क्लिनिशियंस की भी ख़राब हो जाती है कि 12 से 13 दिनों में जब पेशेंट मेरे पास आता है, मैं अपनी बात करूँगा, ICU में पहुँच जाता है, उस वक्त तक उसका वायरस ख़त्म हो गया होता है मोस्टली। आपने पढ़ा भी होगा कि वायरस तो नेगेटिव आया, उसके बावजूद जो है वो डॉक्टर कही जा रहा है ये कोरोना है और वो जहर के टीके और ये सारा कुछ आप लोगों ने सुना। एक्चुअली होता उस वक्त ये है कि नेज़ोफेरेंस में वायरस लोड ख़त्म हो गया होता है, तो हमारा जो PCR है वो उसको पिक नहीं कर पाता है। सारे का सारा फसाद उस वक्त लंग्स में ट्रांसफ़र हो गया। लंग्स में उस वक्त जो है एक इन्फ्लेमेशन का एक तूफान मचा होता है, और उस तूफान की वजह से एल्वियोलाई आर फिल्ड विद द इन्फ्लेमेटरी फ्लूइड्स एंड द गैस एक्सचेंज इज़ नॉट हैपनिंग। तो आप उसको जब ट्रीट करते हैं स्टीरॉइड्स के साथ, और आप उसको ट्रीट करते हैं टोसिलिजुमैब के साथ, तो वो जो है वो इन्फ्लेमेशन सेटल हो जाता है, राइट। तो अब प्लाज्मा देने का जो पिछले दिनों तूफान मचा था, उसमें सबसे बड़ा जो हमें डैमेज हुआ वो यही हुआ कि प्लाज्मा दिया जाता रहा है लेट। तो लेट प्लाज्मा जो है वो हेल्प नहीं कर सकता था। अगर प्लाज्मा आप दें ना पहले 6-7 दिनों में, तो फिर हम समझते हैं कि वो एंटीवायरल के तौर पे काम करेगा। अब ज़रा गौर से मेरी बात सुनिए कि पहले 6-7 दिनों में तो पेशेंट इतना सिक ही नहीं होता। जब पेशेंट सिक ही नहीं होता और आप उसको प्लाज्मा सजेस्ट करें तो वो तो नहीं मानेगा, वो तो कहेंगे ये तो पागलों वाली बात है, मुझे तो ज़रूरत ही नहीं है इसकी। तो इसलिए मेरा ज़ाती ख्याल ये है कि प्लाज्मा के ऊपर जो हमारी एक्सरसाइज है वो इसलिए कामयाब नहीं हो सकी है। अच्छा, उसके बाद जो अभी आपको देखिए जो करंट हमारी जो रिकमेंडेशंस हैं, वो डिजीज़ जो सेंटर ऑफ डिजीज़ कंट्रोल है यूएस का, उन्होंने हमें कोई क्लियर गाइडेंस जो है ना वो नहीं दी कि आपने ये दवाई इस्तेमाल करनी है, ये दवाई इस्तेमाल करनी है और ये दवाई इस्तेमाल नहीं करनी। वो यही कहते हैं कि आप सपोर्टिव केयर करें और जो सेवेरिटी ऑफ इलनेस है उसके हिसाब से चलें। मैं ना क्विकली आपको 2 बातें और बताना चाहूँगा। ये देखिए, ये एक बड़ा मशहूर ट्रायल है डेक्सामेथासोन का ट्रायल जो है, इसको रिकवरी ट्रायल कहते हैं। इंग्लैंड में इसने बड़ा अपना जो एकदम से नाम बनाया, और BBC ने और TV ने और सब ने इनको बहुत ज़्यादा प्रमोट किया, और वो पंजाबी में जैसे कहते हैं ना बैजा करा ली, इसने डेक्सामेथासोन जो है वो उसने लाइफ बचा ली, ये कर लिया। ज़रा गौर से देखिए, what they did was in this controlled open label trial they made 2 groups of the people, right? एक वो ग्रुप था जिसको इन्होंने 6 मिलीग्राम डेक्सामेथासोन दिया डेली, और एक ग्रुप था जिसको उन्होंने यूजुअल केयर दी। अब जिसको डेक्सामेथासोन दिया है, याद रखे उसको यूजुअल केयर भी मिल रही थी। यू अंडरस्टैंड? तो यहाँ पे देखिए मैंने लिखा है कि टू रिसीव ओरल और इंट्रावीनस डेक्सामेथासोन एट ए डोज ऑफ 6 मिलीग्राम वंस डेली फॉर अप टू 10 days, और टू रिसीव यूजुअल केयर अलोन, राइट। सो दोनों ग्रुपों को दोनों केयर मिली, एक ग्रुप को सिर्फ डेक्सामेथासोन एक्स्ट्रा मिला, राइट। अच्छा, अब टोटल 2104 पेशेंट्स जो थे वो उनको डेक्सा मिला, और 4321 पेशेंट्स को यूजुअल केयर मिली। आउट ऑफ दैट 22% पेशेंट्स जो डेक्सा ग्रुप में थे वो एक्सपायर हो गए, और तकरीबन 25.7% पेशेंट जो थे वो दूसरे ग्रुप में दे एक्सपायर्ड। अच्छा, अब उन्होंने रिजल्ट देखे हैं कि जो डेक्सा ग्रुप है उसमें इंसिडेंस ऑफ डेथ वाज लोअर, तो वो इस पे बड़े ज़्यादा सब खुश हुए। और से मेरी बात सुनिए कि एक्चुअली हुआ क्या है, द प्रोपोर्शनल एंड एब्सोल्यूट बिटवीन ग्रुप डिफरेंसेस इन मोर्टेलिटी वेरिड कंसिडरेबली अकॉर्डिंग टू द लेवल ऑफ द रेस्पिरेटरी केयर। जो कि रेस्पिरेटरी केयर मिली थी ना, उसका गौर से बात सुनिए कि ऐसे पेशेंट्स जिनको ऑक्सीजन मिल रही थी उनमें एक्सपायरीज कम हुई, ऐसे पेशेंट जिनको बाईपैप लग रहा था उनमें एक्सपायरीज कम हुई, ऐसे पेशेंट जिनको आपने वेंटिलेट किया तो उनमें एक्सपायरीज कम हुई। तो कहने का मतलब ये है कि ये अकेले डेक्सामेथासोन का कमाल नहीं था, ये ऐसे ग्रुप, दूसरा ग्रुप जो है अगर आपने नो रेस्पिरेटरी केयर दी रेंडमाइजेशन पे तो वो पेशेंट जल्दी एक्सपायर हो गया बिकॉज ऑफ हाइपोक्सिया। लेकिन एनी हाउ कहने का मतलब ये है कि डेक्सामेथासोन ने फिर भी बाकी जो मेडिसिन हैं उनके मुकाबले में आपको थोड़ा सा रास्ता दिखाया है कि आप इस तरफ लेके चले, यहाँ से हम पेशेंट्स को बचा सकते हैं। और दूसरा जो है वो आप ये देखिए कि वो है रेमडेसिविर। अब रेमडेसिविर जो है ये एक डबल ब्लाइंड रेंडमाइज प्लेसिबो कंट्रोल ट्रायल है इंट्रावेनस रेमडेसिविर का, जिसमें उन्होंने 2 ग्रुप बनाए थे। एक ग्रुप को उन्होंने 200 मिलीग्राम लोडिंग डोज दी डे 1 पे, फॉलोड बाय 100 मिलीग्राम डेली फॉर 9 एडिशनल डे, और दूसरा जो ग्रुप था उनको सिर्फ प्लेसिबो दी। अब रिजल्ट्स उन्होंने जो देखे वो ज़रा थोड़े से इस सेंस में बड़े अट्रैक्टिव हैं कि आउट ऑफ 1059 पेशेंट्स 538 को रेमडेसिविर मिली और 521 को प्लेसिबो मिली। तो देखा ये गया कि जिनको रेमडेसिविर मिली थी उनकी जो रिकवरी टाइम है वो 11 डेज था एज़ कम्पेयर टू दी प्लेसिबो ग्रुप जो कि 15 डेज था, राइट। तो 4 दिन जो है वो अर्ली रिकवरी जो है वो रिकॉर्ड की गई, और कॉन्फिडेंस इंटरवल जो है वो 95% है फ्रॉम 13 to 9। तो दैट इज़ वाई उन्होंने कहा कि ये जो ड्रग है इसने तो कमाल ही कर दिया, और वो कमाल अभी तक उसके ऊपर जो फर्दर, ये प्रिलिमिनरी रिजल्ट्स हैं, इसके ऊपर फर्दर अभी डिटेल जारी है। और एक जो इसका मोर्टेलिटी एस्टिमेट था बाय 14 डेज वो 7.1% था रेमडेसिविर से, और प्लेसिबो में 11.9%। ये जो थोड़ा सा है, इसको मैं किसी हद तक समझता हूँ कि एक इम्पॉर्टेंट बात है कि जो मोर्टेलिटी है वो इस ग्रुप में कम है जिस ग्रुप में रेमडेसिविर है। लेकिन आप सब लोगों को मैं ये बात बताना जरूरी समझता हूँ कि ये सारे लोग वो हैं जिनको साथ में वही बात की टक्सा भी मिली और साथ में ऑक्सीजन भी मिली। तो यू कैन नॉट रियली गिव ऑल द मेडल टू रेमडेसिविर। यू अंडरस्टैंड कि दोनों ग्रुप्स में, तो आप एक चीज़ याद रखिए, कोई भी क्लिनिशियन जो होता है ना, उसकी एक इंटेंशन होती है, उसे कहते हैं इंटेंशन टू ट्रीट। कि मैं अगर 2 ग्रुप में लेके चलता हूँ ना पेशेंट्स को, तो एक ग्रुप में मैं दे रहा हूँ दवाई और दूसरे में नहीं दे रहा हूँ। 2 दिनों में 3 दिनों में जब मुझे अंदाज़ा हो जाएगा ना कि ये जिस ग्रुप में मेडिसिन नहीं मिल रही, इस ग्रुप में मुझे मोर्टेलिटी ज़्यादा मिल रही है या मॉर्बिडिटी बढ़ रही है, तो मैं उसको स्विच कर दूँगा फ़ौरन से पहले कि मेरा पेशेंट ही ना ख़राब हो जाए। तो इसलिए इस पर जो डबल ब्लाइंड रैंडमाइज्ड कंट्रोल ट्रायल्स हैं वो भी होने बाकी हैं अच्छी तरीके से। तो आप ये देखिए कि अभी तक जो मैंने आपसे सारी बातें की हैं उसमें मैं लास्ट में आपसे ये कहूँगा कि जो सबसे इम्पॉर्टेंट चीज़ें सामने आई हैं वो है एक तो स्टीरॉइड्स, दूसरा इंटरल्यूकिन 6 इनहिबिटर, और तीसरी बात जो कि अब मैं आई विल नॉट गो इनटू डिटेल, मैंने काफ़ी आप लोगों का टाइम दे दिया, वो है एंटीकोएगुलेशन। एंटीकोएगुलेशन पे हम लोगों ने एक कौन सी एक्सपेरिमेंटल स्टडी जो है वो अभी पब्लिश करने के लिए भेजी हुई है। हमने क्या किया था, शुरू में ही हमें अंदाज़ा हो गया कि डिस्पाइट ऑफ द फैक्ट that we are giving them prophylactic vaccine, people were developing clots. So we started to give them therapeutic anticoagulation. अब therapeutic anticoagulation में मेरे ज़ाती ख्याल में बहुत बेहतरी दिखाई है। People were able to get off from ventilators, we were able to send them home, एंड अभी तक एक महीने तक आप देखें उनके, मैं आज भी अभी फॉलोअप में क्लिनिक में पेशेंट देख के आया हूँ, उनकी डी डायमर्स अभी भी किसी का 1100 है, किसी का 1300 है। 2 महीने हो गए हैं, 1.5 महीना हो गया है मैंने उनको ओरल एंटीकोएगुलेशन पर रखा है। सो एंटीकोएगुलेशन एक बात, स्टीरॉइड्स इन टाइम दूसरी बात, इंटरल्यूकिन 6 इनहिबिटर तीसरी बात, और चौथी बात ये याद रखिए कि व्हेन यू स्टार्ट गिविंग देम इम्यूनोसप्रेसेंट्स लाइक डेक्सामेथासोन एंड इंटरल्यूकिन 6 इनहिबिटर्स, दे आर प्रोन टू गेट इन्फेक्शंस। सो प्रॉपर टाइम पे एंटीबायोटिक्स देना जो है वो बहुत ज़्यादा जरूरी है। सो विद दिस आई विल ट्राई टू कंक्लूड। अगर इसमें मैं किसी भी जगह पे कोई कंफ्यूजन है, आई वुड लाइक टू हेल्प, अदरवाइज आई विल एंड माय टॉक हियर। Thank you very much for listening.
Thank you so much, sir. It has been really great pleasure to have you, and you have shared like a lot of experience. Or I have seen you working on frontline. Actually, I've been visiting Baria Hospital for quite a while with my mother. So, mashallah, everything was covered. But only one question that is everyone is waiting for, that is when we are going to expect a vaccine for that. So I hope that would be.
What I would rather, what I have seen here is that virus is changing. Most of the viruses strains have changed. अभी तक आप यकीन करें 3 पेशेंट्स मैंने देखे हैं जो कि जिनको हमें लगता है कि इनको रिकरेंस होगी। तो आप ये देखें कि अगर रिकरेंस हो रही है तो मीन दैट वायरस से जो वैक्सीन है वो तो भी दूर है, क्योंकि अगर वायरस म्यूटेट किए जा रहा है तो उसकी वैक्सीन बनाना probably एक खासा मुश्किल काम होगा। That is why we have not been able to make a vaccine for HIV virus also. अभी जो स्टोरीज हैं वो सारी स्टोरीज हैं, हनूज दिल्ली दूरस्त। I do not see vaccine coming in next few like 5-6 months. अभी सबसे ज़्यादा ज़रूरी मैसेज जो बल्कि इसमें होगा वो ये है कि अब सेकेंड वेव जो है पाकिस्तान में थोड़ी थोड़ी जो है वो होना शुरू हुई है। US and England and other people they are already suffering. हम लोगों को अपने लोगों को बचाना है, उनका ख्याल रखना है, टाइमली इन्वेस्टिगेट करें, टाइमली जो भी आप उसको इस्तेमाल करा सकते हैं लाइक स्टीरॉइड्स हो गए, ऑक्सीजन हो गई, दैट इज़ वैक्सीन प्रोबेबली आपका आई कैन नॉट रियली आंसर विद कॉन्फिडेंस। मे बी जो हमारी यूके से कोलीग्स हैं दे माइट बी एबल टू टेल कि वहाँ पे क्या काम हो रहा है। we are looking toward west. आपको पता है कि वो वैक्सीन बनाएंगे तो हम मार्केट में शो करेंगे.
Inshallah. Thank you so much, sir, for your time. And inshallah, we will
thank you very much. Dr. I want to ask a simple question. It's a rumor or a reality that a second wave of this pandemic is coming in upcoming winter. Please highlight on it.
Rumor, if you just try to understand it this way, that how does a second wave happen? The second wave actually happens is कि कुछ patients या कुछ आपके जो careers हैं ना वो dormant हैं, right? जैसे मैंने आपको अभी बताया, एक मेरा patient है, उसके he is still positive after 6 weeks of treatment, 2 courses of remdesivir. Now this patient is a potential candidate to spread it. Clinically he has improved, psychologically he is at the moment वो बिल्कुल एज पे है, बहुत ज़्यादा इची हो गया है, वो कहता है मैंने कमरे में नहीं बैठना, 1.5 महीना हो गया मुझे बंद हुए. सो ही इज़ ए पोटेंशियल कैरियर. टू अंडरस्टैंड, इस तरह के केसेस जब बाहर निकलेंगे और वो स्प्रेड करेंगे डिजीज़ को दोबारा, और फिर वही बात, आई एम सस्पेक्टिंग दैट दिस पेशेंट इज़ हैविंग ए म्यूटेटेड वायरस which is not getting killed by the usual remdesivir or the antiviral which we have been using. You understand my point? So the virus which already has mutated, if this virus comes out and starts spreading, so the second wave will definitely come. But the only problem is if we continue with social distancing और कहीं sporadically आपको 1 या 2 पेशेंट्स मिलते हैं, उनको आप हैंडल कर सकते हैं आसानी से. मैसेज जब बीमार होनी शुरू हो जाएंगी तो सेकेंड वेव को फिर कोई नहीं रोक सकता. लेकिन जो आपका क्वेश्चन है कि ये र्यूमर है या रियलिटी है, मेरे ख्याल में ये रियलिटी है. वी हैव टू टेक केयर, इसको र्यूमर नहीं लेना चाहिए. वी हैव टू स्टे फोकस्ड, वी हैव टू स्टे पुट, वी हैव टू स्टे अलर्ट. और चूँकि हमारे पास वैक्सीन नहीं है, the only way we can prevent is by maintaining the social distancing, using mask and washing our hands. This is the simplest way we can still handle this pandemic.
Thank you very much, Doctor. Thank you so much for giving your precious time.
I'm really and it was a pleasure to talk to you all. I have used Urdu language in most of my talk. I was just feeling easy this way. I hope it has not bothered most of our audience.
No, sir, it's not a problem. Our last, thank you very much. Our last speaker of today's webinar is Dr. Kamal Rahman. She is an academic pharmacist currently working as assistant professor at Department of Pharmacy, University of Agriculture, Faizabad. She is PhD in pharmacology from Zhejiang University, China. Dr. Kamal has 13 years of experience in academia and research. She was awarded Research Productivity Award from the Pakistan Council for Science and Technology. She has published 89 research articles with impact factor of 238.73 NH index of 29. Her major research areas are metabolic disorders, especially diabetes. She is also faculty mentor of startup business program at University of Agriculture, Faizabad, and she is also an editor of Journal of Agriculture Policy and Food Security. She has authored 27 book chapters and is currently has supervised 15 MPhil research students and currently supervising 2 PhD projects. She has been awarded various HEC projects as well. I welcome you, Kamal, and it's a pleasure to have you with us.
Thank you very much, Saira, and everyone in this presentation webinar. So I'm really grateful for inviting me and having my viewpoints, because we have already listened to many esteemed pharmacists already over here and Dr. Asim recently. So we have already gained a lot of knowledge regarding this pandemic, which has entered into this world unexpectedly and unpredictably. So I'm really grateful for all the speakers, and especially to Dr. Humaira Majid and all of you as an organizer. So first, I would like to just going quickly through what is this corona actually, which we have all suffered very unpredictably, and it entered into Pakistan, and we were all not quite ready for this pandemic situation. So we have an idea of this COVID-19 that was SARS coronavirus 2, and it has reached the pandemic levels in March 2020. In the absence of the vaccines, and if you say this curative medical treatment, this COVID exerts a record global impact on the public health and healthcare delivery. Because we have already known about the history of the Ebola and other diseases that have a very great impact on this health system as well as on the population, and we were all suffering. Our ancestors or our previous population and generations, they were suffering from these diseases and pandemics, and now we are facing this again in this century of 2020. So owing to this unexpected need of large capacities of intensive care units, you can say beds and hospital facilities and some quarantine isolation centers, we are in dire need of all these things. But our doctors and our respected healthcare professionals, all of them have played the very, you may say, decisive kind of role in just elaborating all of the needs as well as all of the precautionary measures our population needed at this time. So being a pharmacist and working for a long period of time in a research field, and particularly focusing on the pharmacology and some of the disease that are correlated with each other, I chose a topic that is going to be a bit different from the talks which we have recently heard in previous hours in this webinar. So I'll be just locating some of the comorbidities that were maybe a part of the risk factors that lead toward death, or you may say fatalities, at a higher rate than the one which may be expected in the absence of these comorbidities. Because these comorbidities were like the diseases that have already a great impact on the health system, for example, the metabolic diseases. And recently, Dr. Asim has clearly indicated the impact of the respiratory or respiratory diseases as well as the cardiac diseases, that how they can impact this whole pathogenesis of the coronavirus, not only including as a part of this COVID pathogenesis, or they may be resulting as an complication of this COVID-19. So quickly going that what actually happened, what could happen, what has happened in this pandemic, in this world, out of this Pakistan I'm talking about, because unfortunately, when I was collecting this data to present over here, and because I was also interested in doing some future research work based on this COVID-19, so because recently my lab is focusing on some of the pharmacogenomics and the genomic makeup of the population, you may say ethnicity. So I was just focusing on some kind of data that has already been published or been collected in Pakistan, but unfortunately I failed to do that because there was no literature available regarding these conditions, the comorbid conditions, or you may say the pharmacogenomics or the genetic makeup of the Asian population, particularly the Pakistani population so far. But I am hoping that many of the researchers are going to be working on these specialized area or fields of research. So in this viewpoint, I would like to discuss some of these comorbid conditions and the current understanding of the mechanism of these comorbidity involved in COVID-19, and provide a series of recommendations for the clinical practice on the basis of the current clinical experience. Because as Dr. Asim has already shared some of the clinical experience, so I would like to share these comorbidity research work that has been done globally, so that the healthcare professionals over here, we being pharmacists, the one which we are working as a hospital pharmacist, the one which are working in as a community pharmacist, the one that are working along with the doctors, along with the healthcare system, they will be finding it very, very helpful so that they can plan some future multi-directional pathways, and they can treat the patients, and at least if they cannot protect them from the disease, they can protect them from the deaths, or they can at least decrease the mortality rate. So here I will be just sharing some or suggesting some of the future research plans that are actually required to obtain the adequate evidence to support the clinical approaches. So what are the comorbidities that patients with pre-existing comorbidities are thought to be at increased risk of infection with this COVID-19 and tend to have a worse clinical outcome? Why I'm focusing on COVID-19 and with the comorbidities and the patients who are just suffering from COVID-19 is that they are at high risk because they need a double kind of therapeutic interventions, as Dr. Asim has recently talked about dexamethasone, and he was actually recommending dexamethasone if it is given at right time. So if this dexamethasone is given as an immunomodulator at the right time, it can prevent both of the diseases, like the one, COVID-19, as well as it can prevent the occurrence of the comorbid conditions as well. Similarly, some of the antivirals, as well as some of the drugs that can be used for the treatment of the cardiovascular disease. So he has also recommended some of the drugs that can be used. For example, he has talked about anticoagulant. Yes, I will endorse that because anticoagulant will be not only regulating this COVID-19, but it can also help us in removing all of the underlying causes that are in a patient who is already suffering from the cardiovascular. So I think in a right condition, in the right time, being a pharmacist and knowing all the knowledge, we can implement some of the suggestions that our healthcare professionals, being a researcher, being a community pharmacist, being a hospital pharmacist, and being a doctor in the healthcare system, as well as inside that situation and the condition of patient-to-patient interaction, the doctors can suggest. So if I'm allowed, I would like to share a slide. I think, Dr. Saira, it will be more convenient for the audience if I will be sharing this slide so they can see the data, which I have just compiled over here for the research work. So am I allowed to share the screen?
Yes, Kamal, you can share.
Okay, thank you. So I hope you can see the screen.
Yes, we can see.
All right. So the topic which I'm going to be sharing with you people over here is the prevalence and the clinical management of comorbidities. So I would like to make it clear that the clinical management of the comorbidities that I will be sharing over here is only the data that has been collected in the form of a meta-analysis or the research studies that have been done outside of Pakistan. Because inside Pakistan, our respected doctor, the esteemed doctors, including Dr. Asim, he will be more having more expertise in explaining these clinical management, being working inside the hospital situation and the condition. So first, this is an introduction, which we all know about the coronavirus. We know that this is nothing new. We are having this species coming from 1960, and then there were two, or you may say three, coronavirus species that targeted the respiratory system, and these included the Middle East respiratory syndrome, that included the coronavirus, SARS, that was considered as SARS-1 before the occurrence of COVID-19, because this COVID-19 is considered as a SARS-CoV-2, that is coronavirus 2. So we are all familiar with this, and we all know that this outbreak came from Wuhan, China. It occurred in December 2019. And the pathogenesis, it includes different stages. I'm quickly bypassing these slides because we are all having these information before this, and just coming into this pathogenesis of COVID-19. If we go into stage 1, we know that there are some signs and symptoms that will be starting from myalgia, or you may say fatigue, some headache, dry cough, and immediately converting into some of the severe signs and symptoms. Along with a fever that will be greater than 100 degrees, and this will be including some of the symptoms like shortness of breath. And if this shortness of breath is indicated by any patient, definitely he will be moving out for some assessment or diagnosis or analysis. So there will be a sign or clinical sign of abnormal chest imaging, and some of the low calcitonin is not actually included in Pakistan, but some of the laboratories or the lab investigations outside of Pakistan is focusing on this level. So we can skip this calcitonin concentration here in as a clinical sign. And when we are talking about stage 3, this will be having some elevated inflammatory biomarkers, just like the one Dr. Asim has showed about interleukin-6 and some of the CRP and troponin, because interleukin-6 being a pro-inflammatory biomarker will be provoking this whole part of important cytokine family, will be provoking these pathogenesis and converting the condition into a more worsened condition. Similarly, we may be having a patient suffering from acute respiratory distress syndrome, some of the cardiac failure and shock. Now, here the clinical symptom that we can see in stage 3, and many of the reports as well as some of the research studies have also indicated the cardiac failure to occur in patients very quickly, because sometimes the patient gradually develops the stage 1 to stage 2, then stage 3. But once he comes or achieves the stage 3, he will be definitely showing some of the symptoms relating to this cardiac failure. Because if we are talking about the acute respiratory distress syndrome, we all know that this is relating to this respiratory system. But this is kind of new thing, that the cardiac failure or the cardiovascular system, the involvement of the system is occurring in patients who are suffering from COVID-19. So this means that a patient who is already suffering from this cardiovascular disease is at high risk of getting this pathogenesis. Similar is the case with the diseases that are considered to be metabolic or that are considered to be autoimmune, because in autoimmune diseases or metabolic syndrome or metabolic diseases, we know that the pro-inflammatory biomarkers like interleukin-6, interleukin beta, the CRP, and other markers, they will be playing a vital role. So the patients who are already having this underlying cause, if they are suffering from this COVID-19, simultaneously, they will be showing some worse conditions and worse signs and symptoms as compared to a normal patient suffering from COVID-19 only. So there are different diagnosis tools. However, in Pakistan, we are just relying on PCR so far. And we know that IgM, IgG combo test for COVID-19 is done for the patients who are considered to be recovered from this disease, and any kind of antibody presence inside the patient plasma will be indicating the recovery of the patient, as well as it will be cleared for providing the plasma for the plasma therapy or to the patients who are still suffering from coronavirus and are in critical stage. So, however, if we go from a streamlined path, we may be having a travel history, we may be having some normal CBC, we will be getting the chest x-ray, but because we are having an overwhelmed healthcare system because of the load of the population and the patients suffering from COVID-19, it was not feasible for the government or any hospital or any healthcare system to provide all of the facilities, starting from the history taking till the occurrence of the CT scan or the chest x-ray. So we were just relying on the testing facility of the PCR. And similarly, if we are focusing on the comorbidity, why is that? Because there were two major, till now, if I'm talking in August 2020, I will be just focusing on two major factors that are considered to be at high risk of getting this COVID-19. Not only on at risk for getting this COVID-19, but they are at risk of getting cure as well. Because if you are not providing proper or significant and appropriate therapeutic intervention to such patients, they will be definitely going under a more worse condition as compared to a patient only suffering from COVID-19. So the first factor is the age, which is non-neglectable, and we cannot just ignore this factor, because the patient history or the data that has been collected from globally, we all know that the patients who were above 60 were having more deaths. Similar is the case with the comorbidity, for example, the cardiovascular disease, the respiratory disease, or metabolic syndrome, or metabolic disease like obesity or diabetes, particularly diabetes. So what happened in Pakistan? That the first case was confirmed on 26 February 2020, and we were not actually ready for this outbreak, and definitely this COVID-19 has surpassed the death toll of more recent outbreaks like Ebola or the Middle East respiratory syndrome or any other SARS, because Pakistan healthcare system was not designed, it was not ready, though our healthcare providers, they played their critical role, their vital role, and their best for giving out whatever they can. So we appreciate them, really we appreciate them. And so this is the recent condition of what we are now having, because now we all are concerned about the second wave, as the question was raised over here, as Dr. Asim has shared, and we all know that the second wave is about to come, and maybe maybe this is to somehow true for many of the carriers, asymptomatic patients, that they will be transmitting this disease to other people. And if we are not having proper SOPs followed at the workplace and at the other areas. So this is the last 15 days data, which we all know that the recovery is more than the active cases. It is more than the death cases or death toll. So this is a good indication, but it will be only good if we continue on following the SOPs that are provided by the government or the National Institute of Health. So why we are having more problems in the comorbidities, or why the patients who are suffering from the other diseases like cancer or even diabetes or cardiovascular disease. I'm just focusing on cardiovascular disease and diabetes because these are the foremost diseases found in Pakistan, as well as on just going through this growing literature of COVID-19. I found that these two were having the greatest percentage for having influence on the COVID-19 patients. So that's why I'm just focusing on the cardiovascular disease as well as for the diabetes, rather than other fatal diseases like cancer. We cannot ignore them. However, the situation is just like as simple. We just become more stressful because of the lockdown, the anxious, depressed. We are not mobile. We cannot do our routine works in a routine manner, and there will be some sleeping disorders, there will be an imbalanced diet or an unhealthy diet, or maybe we will be more conscious in taking some suboptimal diet contents or nutrients. And similarly, a patient, we all know, suffering from a disease like diabetes need a regular routine checkup for proper maintenance of the glucose, for the hypoglycemia, the drugs he is taking. He should be very good at taking the routine diet as well as routine drugs on time. But once he missed the drug, once he missed the routine visit, will be definitely prone for getting this disease. So this will be at risk. And this is a great challenge, not only for the patients suffering from diabetes or cardiovascular disease. I'm telling you, this is also as same for other patients who are suffering from fatal diseases or from chronic diseases like respiratory diseases or cancer and some of the gastrointestinal diseases. So just going forward, because I found more data regarding these two, I'll be sharing, because respiratory disease is already explained very well before my presentation. So I'll be just focusing on these two because meta-analysis of almost 8 studies, when it was compiled, it was found that around more than 46,000 COVID patients, they were having a comorbidity of diabetes, cardiovascular, and a symptom of hypertension as well. Though they were healthy, their cardiovascular system was healthy, but they were still showing the signs and symptoms of hypertension. They were suffering from some sodium retention. They were showing some increase in the blood pressure. That was definitely forming a platform or forming a base or pathogenesis for inducing other diseases like diabetes and cardiovascular disease. So definitely this hypertension is considered as a risk factor or as a factor that will be provoking some other diseases during this COVID-19. So this was data collected by Our World Data, and this is an authenticated site that has provided this recent outbreak that was found in Wuhan, China, and they confirmed that during this whole period of COVID situation, they found the patients that were at risk of getting COVID, as well as they were not moving towards a recovery phase, rather their condition was getting worsened, were the people or the population that were suffering from cardiovascular disease and diabetes at top, followed by the chronic respiratory disease, hypertension, cancer, and when they were compared with the no health condition, which were the individuals with the no condition were vulnerable to get cured. They were vulnerable to get recovered. However, unfortunately, you can see that 10.5% of the cardiovascular disease, the people who were suffering from this, they were diagnosed with COVID-19 and they all died. So that's why this is a very, very important, you may say, area or research field that still needs to be focused. I'm really, you may say, focusing on this, that in Pakistan, being a researcher, being a part of this academics, I will be interested, as well as I will be trying to collect more of the data regarding this comorbidities that has occurred in Pakistan along with COVID-19 and what was their fate. So as I told that the two major factors, you can see the graph over here, that is 13.7% were the people who were greater than 70 years old. So this was the number one factor that affected, and the other were the disease condition. Again, we can see the cardiovascular disease. We can see the diabetes at the top two position, occupying still the top two position. However, this is the data that was collected by some other study other than the one that was conducted in Wuhan, China. So going again towards the cardiovascular disease as a comorbidity in COVID-19, the patients who are suffering from this cardiometabolic disorders are at potentially higher risk when we are comparing to the other patients who are suffering from COVID-19 in terms of fatality, because more death is occurring in the patients who are suffering from this. And we can see early reports from China, 17%. Some of the patients, they were suffering from arrhythmia, and this was around 44%. And they were immediately entered into the ICU of the hospital, and unfortunately, more of them were reported to die because of this underlying cause. So this is a whole status of another study. I'm just giving a collection of study over here because all of them, they are correlating with each other, because when we are looking into the growing literature or in the publications, we are not having data in a compiled form under one roof. So I'm just sharing with you people some of the data which I'm interested in. I have shared you that the people who were already suffering from the CVD, you may see over here a study that was done in 2019, again from Wuhan, China. This was having a total people of 700. And out of which 79 were taken into ICU, and around 621 were non-ICU patients. So you can just see the difference over here. On the right side, these are the admission status and some of the events that they were suffering from, the bradyarrhythmia or the incidence of atrial fibrillation or some of the ventricular tachycardias. However, I'm not going into detail of these symptoms. Just looking onto the left of the study population, we can collect the data from here that the people, they were 45% male, they were 71% black, and they were 50 years old. They were the patients who were in ICU, 79%. They suffered from these cardiac symptoms, and about 23% of those patients, they faced death. So this means that if we are not looking into, and it is not necessary that these patients will be living up to the stage 3, as I have just discussed in the above slides, that we are having stage 1, stage 2, stage 3. Some people are gradually moving up, some of them will be rapidly going to stage 3. However, the patients who are already suffering from this CVD, they might be having a very quick journey from stage 1 to stage 3, unfortunately, and they will be leading towards that. So what we can do over here, there are some mild symptoms, and we can just treat them at home if they are having their medications with themselves, because in the early noon or afternoon, we have heard from Ms. Mehnaz that she was telling that we were having telemedicines, we were remote controlling all of the patients, there were no need for isolation centers or the quarantine. We were just focusing on the patients who were having home isolation. We can just guide them through the telemedicine. So there are some patients, even in Pakistan, we can find some of the patients, but unfortunately, we need to focus on this course or this area as well for the telemedicine, and being a pharmacist particularly over here. Similarly, some of the modern severe symptoms, they need some of the lab investigations, they need admissions to the hospital, they need proper screening, they need proper diagnosis, so that they can be treated for the underlying cause as well as for the influenced COVID-19. So a question may arise that what actually happens if a patient is having a COVID-19? Why we are thinking that this is directly relating to this cardiac disease or cardiac malfunctioning? So we can see quickly that there are some direct viral damages and some indirect viral damages. The direct viral damage will be definitely acting on the myocardium directly, and the one which we are talking about with the slow progression is the one through the indirect pathway. This includes the immune inflammatory responses, some of the acute respiratory distress syndrome, hypoxemia. And again, what we'll be meeting all cytokine storm like interleukin beta, interleukin family, and they will all be involved in just abruptly moving towards deep pathogenesis, myocardial damage, endothelial dysfunction, plaque instability, rupturing of the atherosclerosis and thromboembolism. And definitely if there will be occurring such kind of conditions, we will be ending up with myocardia, and we will be ending up with arrhythmias and some of the heart failures and strokes and all of those complications of cardiovascular system. So these are some of the, if you people are interested, I'll be definitely sharing these slides with Dr. Saira. I'll be providing these slides to you as well. So what are the different challenges? If we are talking about the management, what we can do, if we are having a knowledge, we have the data collection, what we can do for the patients who are having a history of CVD and they are now suffering from COVID. We need a cardiovigilance, a serious kind of cardiovigilance. Why? Because this cardiovascular disease is not only a risk factor for COVID-19, but is also a differential diagnosis for COVID-19. I'm repeating it, that this cardiovascular disease is not only a risk factor for COVID-19, but this is also a differential diagnosis for COVID-19. So we need a very serious kind of this cardiovigilance, and our doctors should, our physicians should definitely focus on such kind of things in Pakistan as well. And the healthcare system, we should involve these systems, looking towards one which has been adopted by USA or has been adopted by UK. Similarly, if I'm talking about the second and the last comorbidity, I will not be discussing more than these two, because these two are the top most important one, and they have shown data overall globally present. So diabetes mellitus, along with other symptoms like hypertension or coronary artery disease, cerebrovascular disease, is one of the major risk factors for causing influence on the patients, moving them towards the COVID-19. And similarly, a larger study of more than 72,000 patients with COVID-19 in China indicated that patients with diabetes had a 3-fold higher mortality rate compared with the mortality rate in the COVID-19 patients overall. And this is threefold means threefold greater chances for death in the patients who were suffering from this COVID-19, having an underlying cause for this diabetes. They were suffering from diabetes before. And this is published in 2019 with a very high reputed journal, the New England Journal of Medicine, around impact factor having around 23, I think, or more than. So this is COVID-19 and diabetes. This is again you may say, a control log for glycemic control, comorbidity control. I will be coming towards the comorbidity control, but quickly looking into glycemic control, we should be knowing what to do with asymptomatic infection. We should be knowing what should we do with symptomatic infection, or patients who are suffering with severe illness of diabetes. So when we are coming to comorbidity control, yes, there are many of the research articles that are indicating that we should be very, very conscious while using the angiotensin converting enzyme inhibitors or the angiotensin receptor blockers while treating the patients with COVID-19. This is because that sometimes it has indicated that this can provoke the direct or the indirect pathway for the damage of the cardiac or the myocardiums. I have just told about the direct and indirect that is occurring via the COVID. And sometimes what happens that in the presence of the COVID, these drugs can block the receptors and they can just promote the production of the interleukins and some of the cytokines, and they will be doing the same thing that a COVID-19 virus can do. However, this is a controversial, because many of the studies, you may say the autopsy studies, the studies after postmortem, they have not found a significant kind of result, or you may say evidences to support this statement. However, if it is indicated, we should be very conscious while using them. Otherwise, we can use all of the symptomatic drugs for treating those patients, as well as the drug or the protocol that has. So for the glucose man, having moving quickly into this slide, because this will be explaining it more. Or hyperglycemia. administered anti-diabetic drugs rather than directly going into an IV of insulin, because we'll be saving this insulin for the patients who are in critical conditions, who are suffering from diabetes as well as COVID and are at the later stages or at a critical condition. So first, if the patient is stable, his diet is normal, and he is self-quarantine, we can use these oral administered drugs as diabetic medications. However, we are definitely following the therapeutic regime and the precautions as well. For instance, that metformin is not recommended for the patients who are already suffering from some of the gastrointestinal problems, or the patients who are suffering from hypoxia. So it is not suitable for them. Similarly, if I'm talking about the DPP-4 inhibitors like sitagliptin, we will not be preferring this sitagliptin to the patients who are already suffering from some of the gastrointestinal problems. So we'll be not promoting that PLP production by inhibiting this DPP-4 enzyme. We all know about these mechanisms, the pharmacist over here. So then we are moving towards a moderate condition of the patient, and this is also again managed with the orally administered drug. But if it is moving rather than recovery towards recovery into a worsening condition, the patient is switched from an orally administered anti-diabetic drug to an insulin for the patient with obvious COVID-19 symptoms who cannot eat regularly. Definitely the other signs and symptoms will be supporting the change from mild to moderate and the change of the regime as well. So suggesting the switching of this premix insulin regime to basal bolus regime or insulin pump to a flexibility managed off glucose. Similarly, if you're talking about the severe and critical condition, we can all see, yes, we can go for a continuous renal replacement therapy, or we can go for an IV insulin as a first-line treatment, and definitely will be managing all of them. But the thing to be noted over here is that when we are talking about the orally administered drug, we all know the side effect of these. For example, if we are talking about thiazolidines, they will be showing some of the hypoglycemic effects, and we should monitor those hypoglycemic incidences as well. So what we need to do, lastly, but not the least, I will be sharing some multi-dimensional future work plans that are really needed by Pakistan in terms of comorbidities. Because these comorbidities, if not recorded, if they're not monitored inside Pakistan, it will be very difficult to treat any kind of epidemic, even epidemics inside our country. So we'll be taking this whole pandemic situation as a challenge, and we should move forward taking some of the future plan work in our own fields, retaining to our own fields, like being a researcher, being a hospital pharmacist, or being any role we can play in our healthcare system. So what we need to do, and we should suggest for the policymakers as well, like at the government level or other thing, that we should reveal and identify the outbreak. Yes, we should. We should map down all of the epidemics, including the comorbidities and the spatial segmentation dynamic mapping as well. So this will be helping out a lot, and after just following these points, we can develop and test the hypothesis, the planned studies, including the spatial dynamic balancing of the supply of demand of medical resources, particularly to the patients who are suffering from comorbidity. And finally, what we need to do, what I have suffered while preparing to present with you people over here, was the lack of literature over here in Pakistan. So we need to communicate. Yes, we really need to communicate. And we need to arrange such wonderful kind of webinars, which we are just having over here with all of you. So we really need to communicate the findings, being the part of the healthcare system and things like that. So I'm really grateful to all of you, and really thank you for giving me the time and listening to me as well.
Thank you, Kaval, for being with us and sharing a massive amount of research information. And initially, you have talked about pharmacogenomics, which is lacking in Pakistan. However, there are a lot of things which are lacking. So what do you think will be something new for the researchers in case of pharmacogenomics?
Well, if I'm talking about this race and ethnicity, this is really an important factor to be focused on, and of my interest as well in future. So if we talk about the experience from the United States and the UK, which have suggested that this race and ethnicity may play a role in severity of COVID-19 infection. So data from the CDC and other associations like International Diabetic Federation and other general recommended associations, they have found that in patients hospitalized for COVID-19 disease, the patient, for instance, I have just shown a slide to you people, and you have noticed that the patients were belonging to a Black race or Black ethnicity. So they have represented a greater percentage of disease as well as of mortality rate. And this suggests this proportionate impact on ethnicity. So I think that if we are focusing on research and we can collect data regarding the patient's genomic makeup, for instance, we know that a population who are having some mutations or some single nucleotide polymorphism in their genes, they are at higher risk to the normal patients who are not having those mutations, those who are not having the sequence, they are not having some single nucleotide polymorphism. So we may just create a library, we can save the data, so such people can go detect a mutant single nuclear polypeptide polymorphism over there. They can be just suggested for as a high-risk patient. We can just indicate them as a high-risk patient. Yes, and that I think may be helpful in future.
Okay, thank you, Kamal. It was great having you with us. It was great having you with us. Now I would like our director, Dr. Humaira, to please say a vote of thanks to the speakers.
Dr. Kamal, thank you very much for such a wonderful contribution to the webinar. Definitely the slides which you've shown us, it's beneficial for our students as well. I would like to thank Professor Dr. Anjum Zia, Mass Comm Department, and Mr. Ahmed, the Technical Director to the department, who helped us in conducting this webinar. And thank you to the faculty. Thanks for the participants to be here with us. And lastly, thanks to the Vice Chancellor, Professor Dr. Bushra Mirza. Thank you very much.
Thank you all. Thank you, audience, for joining us. And I would like to especially thank my co-organizers, Ms. Bazga Gul and Ms. Nabila Tabassum. I would also like to thank Ahmed, who is currently providing us all the technical support from the Mass Communication Department. And obviously the head of the Mass Communication Department, Professor Dr. Anjum Zia. Thank you. Take care. And Allah.